Persons, Dr. Umesh Gedia, MD Medicine, Consultant Physician and Diabetologist, and Dr. Mustafa Rangwala, MD Practicing Physician, Diabetologist. Over to you, Chairpersons.
Good morning to all the speakers and the virtual audience. I feel they are there. Clusters of type 2 diabetes. That is what I told you because it's an insult to the oration ideally. That is what I felt. But then I was compelled to chair the session in time. And that is what Bansi wanted us to do. So we just left the thing and came here. Because I was just going to start that way, going to multiply. Good morning, all of you. And so let's try to make the best in the best hall by starting in time. And for that, in the first talk, we have none other than Dr. Mangesh Tivaskar. To introduce him, he is an MD Medicine, FRCP, London, Ireland, Glasgow, Edinburgh, FACP, FICP, FGSI, Diploma in Advanced Diabetology, Denmark, consultant physician and diabetologist, Shilpa Medical Research Center, Mumbai. And he has been a gold medalist all throughout, editor-in-chief of JAPI on editorial board of Medicine Update IJD, guest editor in Sulite Journal, World Journal of Anemia. And to his credit, he has 74 publications in peer-reviewed national and international journals and has delivered more than 1,000 lectures at national and international conferences and has multiple chapters, poster presentations, write-ups in textbooks. Has been an MRCP examiner at the Royal College of Physicians, United Kingdom. Over to you, Dr. Tawasi.
Oh, thank you, Dr. Mustafa, and good morning, everybody. I really appreciate the presence of true legends here. My friends, Dr. Anjana, Dr. Arvind, Bansi, of course, and Sanjeev, Dr. Urmandru. Thank you very much for this wonderful, wonderful opportunity. I know Bansi has given a title of, learning from the legends, and I started wondering, are we really, and thank you entire DICON team, actually. I feel always homely whenever I am here in Ahmedabad. Now, for this particular talk, I do not have any specific conflict of interest, but also I would say that in some of the slides that I'm going to present to you, probably I'm going to mention Dr. Anjana and Dr. Mohan more frequently. A uniform slide that you would have seen throughout the conference, but I want to draw an attention to this part of the story, where we always compare ourselves with China, and we always talk about the Pacific nations and the Southeast Asian nations. But we need to understand that China is witnessing a real drop in the incidence of diabetes. And look at the overall Southeast Asian countries, which comprises of Bangladesh, India, Nepal, Bhutan, Maldives, Mauritius, and Sri Lanka and Nepal. Mind well, Pakistan is not a part of the Southeast Asian Federation. And what we have witnessed in this IDF data, which was published last year, is this, that currently we stand somewhere around 74 million people with diabetes. But we never talk about this, and very rarely we discuss about this in a conference like this. In fact, as Bansi is very passionate about type 1 diabetes, we should also start probably segregating our type 2 diabetics as well. So is our phenotype different? Are our type 2 diabetics equivocally same? We always have talked about the Indian specialty, thin fat Indian. Look at the amount of diabetes that we get with the amount of the obesity percentage that we have. Well, if you really look at the globe in comparison to the Caucasians or black, on the BMI scale, we do not far at all. But then still the incidence of diabetes is high. And there was a beautiful paper which was published by Dr. Anup Mishra and Dr. Shashank Joshi, where they talked about the Indian specialty of diabetes, and they categorically mentioned about Asian Indians being thin fat Indians or Maun Indians with a very high amount of body fat. Visceral fat is very high. We have thin thighs and legs, we have thin buttocks, but we have got very high insulin resistance. The metabolic syndrome is very high, and we do get a typical phenotypical Indian dyslipidemia, which is a very high triglyceride level, a very low HDL cholesterol, and a very high small dense LDL. And this is the paper which got published in BMJ long back, which talked about overall, if you can see the Asian, whether they are males or females, they have got a far lower lean muscle mass in comparison to the Caucasians. And it does have a genetic connect. A gene named myostatin is increasingly selected for this, and that is responsible for actually development of the skeletal muscles. And this inhibition of this myostatin gives you a very low skeletal muscle mass that leads to a low lean muscle mass. And this was Dr. Yagnik's paper, beautiful, where he starts talking about existence of differences omnes octet right in utero. And he demonstrated, we all have been witness to this, that Indian babies are the lowest birth weight babies in the globe. But still we have got a very high amount of visceral fat. We have got 3 times higher in cord insulin blood levels. And also we have much smaller body, much smaller organs, but a very high ectopic fat deposition or the organ fat deposition. So Indian babies have insulin resistance right from the birth, and it starts becoming visible in the first decade of life mostly. But unfortunately, developing from a thrifty gene hypothesis, which was laid down almost 30 years ago, we have shown that Indians have high insulin resistance, and this is what we believed in, right? But I am going to talk a little bit different from this concept of Indian being labeled as very high insulin resistant population. Yes, we are, for sure we have. But then, are there any different clusters that we have that makes our diabetes little more special and different than comparison to the Westerners? And so many publications. But to specially mention about this paper which got published in BMJ Open Access by Dr. Anjana and team. And I'm very fortunate to have Dr. Anjana witnessing this. And correct me if I'm presenting a wrong data or something like that. And also I had an opportunity to work with the team, and we published a review article on the unique and new clusters of type 2 diabetes in Indian subclass of the patient. And I was very fortunate to be a part of this program, this paper publication also. And we, for the first time, looked at nearly 19,000 patients on 8 different parameters. And what we really looked at, the age of the diagnosis, we looked at their BMIs and the waist hip circumference. We also looked at their A1C or typical dyslipidemia patterns. And also we looked at the stimulated fasting and prandial C-peptide levels. And what we found out is a very interesting data that I'm going to show you. Of course, the highest number is classically mild age-related diabetes that we have. So Indians have 4 clusters. Probably in the Western population, you have 5 or 7 clusters, which I mentioned. But Indians specifically have 4 clusters of diabetes. A mild age-related diabetes is very common. Incidentally common, probably for us. Why? Because we diagnose them fairly fine. And these are the people, those who genuinely develop a age-related diabetes, and they are probably at the low risk of developing complications. But here is something which I want your attention, is the severe insulin deficient diabetes, and that too type 2 diabetes. They have got a very low HOMA beta, they have got very low beta cell secretion, they have got very low C-peptide levels, and they have very high A1C presenting at very young age. And these are the people who are likely to develop retinopathy as a part of the complication. This is the second largest group or the phenotype of type 2 diabetes that we see in India. Then we have got insulin resistance obesity related diabetes, which is called as IRODS. This also presents to you in a very young age, but they do have got a combined insulin resistance as well as deficiency coming up together. And they do have got high BMI, high waist hip ratio, and they do have got a fairly good beta cell function, and these are the people who are likely to develop nephropathy as a very early complication. And the most dreadful of all these 3 or all these 4 is a CIRDD, that is a combined insulin resistance and deficiency diabetes. They have a stormy course. The age of onset is very, very low. They have got a very poor HOMA beta. They have very low C-peptide level. So they are insulin resistant and they are insulin deficient at the same time, and a very high risk for developing retinopathy and nephropathy very early. Remember, Indian subclass of the patients, they have these 2 common features of type 2 diabetic patients, which is mostly neglected, unfortunately. And is there an evidence? Look at the beta cell function. Look at the HOMA beta IR in this patient, HOMA beta, beta cell mass and the beta cell function. If you really compare the Indian population with the Caucasians, you can see the distinct difference between the beta cell reserves in these patients. Even we talk about Chinese, look at Chinese. China guys are better than Indians as far as the beta cell function is concerned. So the racial difference is there, but if you really talk about Asian race, even Chinese are better. So there's something different than what probably we think about. And this is what brings me to a slide which was again a very, very important slide from Dr. Anjana's publication, is an ICMR INDIAB data analysis. And where Dr. Anjana showed us that look at the cluster 1, that is severe insulin deficiencies, IRODS, and the CIRDD. Look at the BMIs of these patients. Look at the age of onset of these patients. They are early 3rd or 4th decades. And look at the BMI, surprisingly. Much lower BMI, much higher presentation of diabetes. This is another beautiful European data which has shown that gone are those days where we talk about Indian people being the insulin resistant people. Look at the the data analysis which is there in the young Indian diabetics. We have got a very high amount of severe insulin deficiency combined with the insulin resistance coming up together. And that makes me to talk to you about this beautiful super hit slide that almost all the conferences we present. A YY paradox. On your left is Dr. Chittaranjan Yagnik, on your right is Dr. John Yudkin from Oxford, and they presented this in 2003, Melbourne IDF. I was sitting, probably Arvind was also there, in the hall. And Dr. Yagnik, very funnily he says that if I would have put even $1 royalty on this photograph, I would have been a millionaire by this time now. But the next picture that I'm going to show you will change your thought process. This is 30 years down the line, same Dr. Chittaranjan Yagnik. You have noticed his fat percentage and Dr. Yudkin's fat percentage. But look at the same Chittaranjan Yagnik and look at his colleague again. Really, I'm not sure about the guy who is next to him. Maybe possibly Dr. Yudkin's son. I'm not really sure. I have not confirmed it with sir. But this was the picture that sir has shared with me. Look at the change in the fat in the European population. So the reason why I'm saying this is because we need to understand the overall pathophysiology, the way we develop our diabetes. As far as an Indian subclass of the patient, we follow a completely different pattern of developing diabetes. Rather than impaired glycemic tolerance, that is higher prandial levels, we follow the track of what is called as a higher fasting level, where the basal metabolic rate is a challenge, the basal insulin supply is a challenge, and with the trivial trigger, the insulin deficiency manifests, in a much higher way. And we do have got a dominant form of impaired fasting glucose, and that is the reason why we do not stay longer in the pre-diabetic phase. We have got a highest conversion rate. We proudly say, even IDF data says that we do not have that much of pre-diabetics, but it's not a very proud thing. Why it happens is primarily our pre-diabetics, they get converted to diabetes very, very rapidly. So if at all we have to talk about preventive diabetology, you need to treat your pre-diabetics equally harsh. And that is the reason why a couple of weeks back in Mumbai, when Bansi was also there, in an IDF symposium on the World Pre-Diabetes Day, we have decided and we have offered that please do not label it as pre-diabetes, call it as an early diabetes, so that all the lifestyle changes can be implemented very fast. So a combination of the evolutionary determined factors versus the lifestyle factors. Me and Anjana were talking, and Arvind were talking about the epigenetics just now. So all these factors are responsible for these different clusters of diabetes. Last 2 minutes, I'll be talking to you about the clinical implications. It's good to know about the clusters of type 2 diabetes. But are there any clinical implications of it? Yes, we do have. Because if you understand the subspecification of your diabetics, especially type 2 diabetics, that will give you a better choice to offer a better therapeutic approaches. Because we always, being the diabetologist, believe in delaying the insulin initiation. And this paper by Dr. Surendra Borgharkar has shown that even though you step up the oral glucose lowering agents, the glycemic control doesn't improve. So we need to understand the need for early aggressive management with the correct therapy, especially when you are choosing your different subclusters of type 2 diabetes. And hence, rather than following the Western guidelines, I strongly believe, and I really appreciate the efforts of RSSDI and Endocrine Society, that we should have a specific India-specific guidelines. And in a quest to that, Dr. Anup Mishra has published this beautiful paper, and he suggested that insulin needs to be really a therapy of choice very early in the patients, as right at the stage 2 level. That is the most important message that I want to give. So friends, when we talk about clusters of type 2 diabetes, I'll need to tell you that yes, we do have got different clusters of diabetes. Yes, we do have got different phenotypes of different types of diabetes. But what is most important thing, you need to choose and diagnose your patients very early, so that in the patients, those who need an early initiation of insulin can be easily picked up, and we can easily offer them that choice of the therapy at the right time, which will save a lot of other challenges. Guidelines, we need India-specific guidelines to follow for our population. Thank you very much for your kind attention. I really appreciate the presence of everybody.
Thank you, Dr. Tivaskar, for enlightening the various clusters of the South Asian diabetics. And now we have the second lecture in this session. Over to Dr. Gadia to introduce the speaker.
Actually, Dr. Arvind Gupta doesn't need any introduction, but for the sake of the people, that he is MD, FRCP Glasgow, FRCP Edinburgh, FICP, FSC, FRSSID, F Diabetes of India, Senior Consultant Physician and Head of the Department of Diabetes, Obesity, Metabolic Disorder, Mahavir Jaipuria, Rajasthan Hospital, Jaipur. Fellowship of American College of Endocrinology, FSC, Fellowship, Indian College of Physicians, Fellowship of Madras Science Foundation, Fellowship of Diabetes India, Fellowship of RSSDI, Fellowship, Royal College of Physician and Surgeon, Awards and Oration, RSSDI Oration, Gold Medal, Hyderabad 2008, Professor Naresh Pau, Oration, Raj, RSSDI, Ajmer 2017, Dr. K.G. Nair, Oration, Indian Society of Hypertension 2017, New Delhi, Outstanding Services Award by Diabetes India 2019, Dr. C.D. Srinivasan, Oration, KRSSDI, Tumkur 2019. He is a chairman and RSDI Rajasthan chapter. He is a joint secretary, Indian Society of Hypertension, organizing secretary, 31st Annual Conference of RSSDI 2003, Jaipur, chairman, Scientific Committee, Diabetic Food Society of India, Jaipur 2013, Program Chair, Diabetes India 2019, at Jaipur, Member Research Committee, National RSSDI Delhi, Co-Scientific Chairman, National RSSDI Jaipur 2019, Member Project Review Committee, ICMR New Delhi, Regional Faculty Diabetes Course, PHFI India. He is Associate Editor, International Journal of Diabetes in Developing Countries, UDDC, presented papers in various international conferences, ADA, IDF, ESD, AAC. Over 90 research papers published in national and international peer-reviewed journals, contributed several chapters in the postgraduate medicine APA textbook of medicine, APM Medicine, Update 2010, 2015, and Clinician Handbook of Diabetes. He is a member of AEC, APIMA, RSSDI, Diabetes India, Chronological Society of India, Diabetic Food Society of India, Hypertension Society of India, Endocrine Society, USA. Over to you, sir.
Hello. Thank you, chairpersons, for this generous introduction of mine. Thank you. And at the outset, I thank Dr. Bansi Bhai and all the team of DICON for inviting me to this beautiful conference. You have just listened to a brilliant lecture by Dr. Mangesh Tivaskar regarding the very specific Indian subsets of the diabetes. But what I'll be talking is little different, that what day-to-day mistakes or errors we are committing, may be voluntary, involuntary, or any type. So that is very, very important to know these inadvertent sort of mistakes which we are doing on a day-to-day basis. And sometimes this is this may have the serious implications for the public and for the patients also. So my disclosures, nothing is very special for this particular thing. So what is important thing here is the medication error, and how these medication errors are defined as any preventable event that can cause or lead to inappropriate medication use. That is very, very important, and maybe we can harm the patient with this medication error. So that may be harmful to the professionals, to the patients, and or to the consumers. So I mean, it is our duty, moral duty, to avoid these type of errors, especially in the insulin treated patients. This is often we do these type of errors. So there are different types of error, dear friends. The errors in the planning and of an intentional act known as mistakes. This is a serious affair. Then errors in the execution of an act known as either slips, that is the acts of commission which can we do almost on a daily basis, or sometimes it is a serious lapses, that is act of omission. Then skill based level, the slips and lapses, rule based, sometimes we break the rule, we don't know how we give the real treatment and prescription to the patients. Sometimes the knowledge based errors which we do, that is we have the knowledge but we don't apply when the patient is in front of us. And then medication error we have already seen. So let us start with the very simple and basic things on a day-to-day basis is the errors in the clinical examination. And that is most of the time in a busy clinic, we don't measure the height and weight of the patient. And this is, that these days we are using GLP-1 receptor agonists, we are using the SGLT2 inhibitors, and especially the biguanides also. So we must know height and weight for the patient, and we should not omit or we should not do this type of. So BMI and height and weight is very, very important. And that is not for the diagnosis, not for the therapy, but for the prognosis point of view also this is important. Then the features of insulin resistance, which is very commonly, we can just look in of the insulin resistance and we can devise or design our medications according to that. Then waistline, most of the times we don't measure, and of course the peripheral pulses often we miss. These days after COVID, we don't see the virtual patients, we see the virtual patient, unfortunately we miss most of the clinical examination which we have learned during our medicine days. So the brood, which is very very, very important, that is a surrogate marker of the coronary artery disease, sometimes we miss, and sometimes the renal brew, because we are giving the ACE inhibitors and ARBs to the patients, and if we just feel the renal brew, and that is the sign of renal artery stenosis, and in that case these are contraindicated drugs. So these type of clinical examination. Then foot examination also, this is very, very important. Last RSSDI we have already Dr. Vishwanathan already has a big drive for the diabetic foot examination, and I mean this is how we can make the people or doctors aware of the foot examination. This is very, very important. Hand, most of the time, sometimes if we examine the hands, the trigger finger, and sometimes we just know some of the clinical diagnosis just by examination. And of course fundus is again sometimes screening, and I have few patients where by just screening, I seen just few days back one patient, just by screening I found that the papilledema is there. Patient has no problem at all, and I find I found that papilledema is there, and that lady I then referred to the neurologist, and ultimately that found to the brain tumor, and she was operated. So just for screening, that is a painless examination, and we can do, we can diagnose so many diseases. A right choice is very, very important. Who should be on the tight control? That is important thing. Like young diabetes without comorbidities, we should have as less as 6.5 or even 6% of HbA1c. For gestational diabetes, I need not to emphasize that this is very, very important, that we have to have very tight diabetes control, blood sugar around 80 fasting, and less than 120 mg% of the postprandial. Post-renal transplant patients also need a very tight glycemic control, and of course during the intensive ICU and the patient on stroke, the blood sugar should be around 140 to 180 mg%. Of course in monitoring, most of the times we do ask our patients to do the self-monitoring of the patients, but they must know the frequency of monitoring, and this is how we all know about this thing, that glycosylated hemoglobin or HbA1c should be done within 3 months. Lipids should be once in a year, or if very high triglycerides or something and we are on some drugs, then if we can think of even 6 months in a year. Then microalbuminuria, fundus, foot examination, we should know the real timelines, how we are going. And this is one of the very important thing, that prescriptions error. This is an important thing in which we do frequently, like especially this insulin error. And if you see here in the insulin error here, that what you are seeing here, just see here, the doctor writes here this is 4 units, but he writes the 4U here, and again 4U and 4U. Unfortunately, this is the real patient, and patient received 44 units twice a day. This is how the errors are being committed. And similarly here, when he wrote the 100 units, this is actually to be 10 units, but unfortunately he wrote the 100 units and patient received 100 units. This is how we have to actually audit our own prescriptions once we are giving, just like in the examination, when we give our prescriptions, the final sheet, answer sheet, we just read twice, at least once. Similarly, if we read once before giving, handing over our prescriptions to the patient, sometimes we may know about these type of errors. Anybody who tells what is the, why I have shown this particular sort of prescription here? Anybody? Is anything error here? Yes, yes. I think you have already seen, and I have taken from that. This is a thing, and this is very commonly, this is, I don't know whether it is involuntary being done, and these days, because these are combination drugs or FDC drugs are available, and probably we don't know the interior content of that thing, and think that this is a 1 tablet and this galvasmet is 1 tablet. Now we are giving 2 types of DPP-4 inhibitors in this patient. So these type of errors we are committing on a day-to-day basis. Then of course, what is our target? We should know our target, giving the target to the patients, and we know about all these things. I will not go into the details. These are just studies, published studies, and where we can actually remit our, we can correct or revise our things. Like this is one of the studies which says that depending on the different types of HbA1c, how much error we are committing. This is one study where if patients are on less than 7%, 33% errors we have committed. Even though patients are at goal, patient is having 7%, but the errors we are doing. If we are around at 7 to 7.79, the goals are reachable here. These type of errors, and I will not go into the details. Again, lipids, as far as lipids are concerned, we never look into the different types of lipids and how to manage. And now, if you see the errors we are committing, this is the international publication. Regarding the treatment strategies, lifestyle modification, we should know that how we educate motivate our patients for doing the lifestyle modifications. At least once the patient is obese or even mildly overweight, then we should aim for 5% weight loss, and at least we must know, and we should give this target to our patients. And of course, for all other things, we should know details of the lifestyle modification to the patients. Then again, this is very important thing. Whenever we are prescribing the oral anti-diabetic drugs, we should know when a drug should be given. Metformin is always, it is always better to give just before or just with meal or just after meals to reduce the gastrointestinal intolerance. Of course, SGLT2 inhibitors I mean, preferably should be given in the morning, because sometimes the frequency of urine is more after SGLT2 inhibitors. Hence, it is preferably SGLT2 inhibitors to be given in the morning. If we are erroneously give SGLT2 inhibitors in the evening, then it is actually difficult for the patients, because in the night he has to wake up several times. Sulfonylurea, again, at least 25 to 30 minutes before, preferably DPP-4 inhibitors before meals. And I think we must know about the insulin, when the insulin should be given, especially the earlier insulin, human insulin, that should be given 30 minutes before, I mean regular insulins or soluble insulins before 30 minutes before the meals. So that is how we should know the timings. Then the storage, again this is very, very important, that we never advise our patients, especially in Rajasthan. I know most of the patients take the insulin, I mean they go to the village and they keep the insulins just in the open, or in the huts, or in their houses. And most of the time bioavailability of those insulin actually reduces, and the whole purpose of giving insulin is foiled. So I mean this is the important thing, the how to storage, and this is very important, especially when the traveling, we should advise the proper storage about the insulin. Dosing errors, still the syringes are available, and we all know that 40 and 100 IU syringes are always there, and mix and match insulins are there. Chemists give some different types of insulin syringes to the patient. Patient doesn't know what type of syringes they have to buy. It is 40 IUs with the 40 IU vial, or 40 IUs, 100 IU syringe with the 100 IU vials. So I mean that is very, very important thing. The dosing errors may be minimized if we educate our patients. So this is again related to injections, and some novel idea you always see with the patients, that sometimes they take insulin injection at anywhere else in the body, and some of the forearms, if you see here, the patients actually take the insulins regularly on the forearms. Doctor doesn't know about that thing. Cleaning is again very important. Sometimes we don't use the good cleaning before the injections, and you find these type of infections. Faulty injection techniques, we have to educate our patients for the proper injection techniques to actually reduce these type of lipohypertrophy or lipohypotrophy. Repeatedly, I have seen some patients that repeatedly they inject on the same sites. That is very, very, I mean, distressing for me, for the patient, because bioavailability, if the injection on the same site, it reduces tremendously. Special precautions, actually the pen users, again the important two things here, the pen should not be stored with the needle. So needle should be removed before the if we store. That is one thing. Second thing, regarding the again we should not store these pens into the inside the freezer compartment. Of course insulin should not be in the freezer compartment. So these two things are important. So there are different strategies. The only thing strategy is to provide the education. Bansi told in the morning that it is for the type 1 diabetes and for all diabetes patients. I think providing good education will increase your therapeutic efficiency. Decision support, changing, if you are not finding the good thing, change your team, or educate your team, or train your team. That is very important thing. And regular audit of your own prescriptions. That is my take home message today, that regular audit, do your regular audit of your own prescriptions. Policy. So the only thing is, again, some stressful situations, what to do during those stressful situations, and on the last, do not chase the blood sugar. That is what we are doing in a hospitalized patients. Even for the diabetes, I mean the patients themselves, they actually just chase their blood sugar. That is the wrong policy. It is a highly individualized art of medicine of practicing diabetes. So you must know all these things. So dear friends, insulin prescribing errors are very, very commonly seen all, not only here but all over the globe. Many strategies that could prevent the harm and use of insulin is just by simplifying and standardizing the many processes. So you just standardize or do your own, the inspection of your own prescriptions, all your own policies in the hospitals. So key takeaways is nothing very special. The only thing is that if you want to improve the compliance and everything, see of everything what I have shown here, the minimum or these types of errors. So to err is the human, and building a safer health system, and what Henry Ford says, the only real mistake is the one from which we learn nothing. Thank you very much.
Excellent elaboration of the topic. Sir, I had a question that, are you following any sliding scale or do you?
Yeah, that is, I think these days sliding scale is not at all justified. And nowhere else now sliding scale, this is individualized. You have to instruct your nursing staff or the staff who is dealing with the in-hospitalized patients, or even for the patients who are type 1 diabetes, sliding scale is not.
Because in many big hospitals also, the surgeons and orthopedic surgeons are using their
So
own
this is
self,
very
their
harmful,
sliding scale.
very harmful. Please do not use the sliding scale, because sometimes the patient is not taking anything, he is having nausea and vomiting, and you have written already 10 units or 12 units insulin at that particular time. The nurse doesn't know, she just sees it is 10 units written, patient is, whatever the patient's condition is there, she gives the 10 units or 12 units injection because you have written it. So it is not, sliding scale is not at all required.
Thank you so much, sir. Thank you.
Thank you, Doctor, for this wonderful enlightenment of what mistakes we make, and we can avoid it definitely. And at the outset, please, the lightmen, please just shut off these lights because it is very disturbing to the people on the stage. Ab pachani light ban karo na bhai. I don't think so it's required. Yeah, it's blinding to the people on the stage. I raised my hands twice, but none of them saw it. Anyway. So now we are coming to the third topic, and that is remission of diabetes. And this is very much in highlight these days, that, and people feel fascinated that diabetes mati shake sahib evu hambryu. And yes, for those who follow certain disciplines, diabetes can be remitted. And to talk on that, we have Dr. R.M. Anchana moving down south. We started from Mumbai, reached Jaipur, and now to Chennai, right? So Dr. R.M. Anchana, she's MD, Diploma Diabetes, PhD, FACP, FICP, FRCP, Glasgow, Edinburgh, London, FACE. Managing Director and Diabetologist, Dr. Mohan's Diabetes Specialty Center and Vice President, Madras Diabetes Research Center and Foundation. Main research areas are prevention of diabetes, epidemiology, physical activity, translational research, and technology related to diabetes. She has been part of many national and international projects, published nearly 300 papers in prestigious national and international peer-reviewed journals, and delivered lectures in several national and international conferences, received several awards, including the prestigious Young Outstanding Women Achievers Award from the Tamil Nadu Dr. MGR Medical University, the Young Innovator Award from the Indo-UK Health Summit Tamil Nadu, Young Scientist Award from Government of Tamil Nadu, Shakuntala Amir Chand Prize from the ICMR, and several others. She is a member of various scientific bodies. I think the list goes on, and in 2020, she has been selected as the member of the WHF Salim Yusuf Emerging Leaders Program as a world-renowned leader in global cardiovascular disease research. How important this award is, everybody will register if they know who is Salim Yusuf. Over to Dr. R.M. Anchana, please.
Sir, thank you very much for the kind introduction. So at the outset, thank you to Banshi sir and the entire team at DiaCareCon for having me here in beautiful Ahmedabad. So I have a very complex topic written there, remission of diabetes in India, new look for recommendations and guidelines. But actually, I'm going to talk about two very simple and hot topics. The first of which is food. And in India, our food is very important. We love our sweets, we love our ghee, and we love our carbs, right? And the second one is diabetes reversal, which is also very, very dear to all people sitting here. So what am I going to be? I have no conflict of interest to declare. If you look at the natural history of diabetes, you typically grow from a state of normal glucose tolerance to pre-diabetes, to clinical diabetes, and then onto the states of complications. So initially, we're talking so much about prevention and progression and prevention of progression, but today we are able to talk about regression or reversal or remission. So what does that mean? Moving diabetes back to pre-diabetes, or maybe all the way back to normal if you have either diabetes or pre-diabetes. So what are the definitions? There are so many terms, reversal, remission, or so many things are there. The correct terminology to use is remission, defined by the ADA as having an A1C of less than 6.5% and or a fasting glucose of less than a 126 for a period of 3 months without medications. So this has just come out and accepted world over. So the first question we ask is remission possible? Someone with diabetes, can you actually remit? The first evidence came from the Counterpoint study in the UK, where they took a small number of people, just 11 with diabetes, gave them a 600 kilocalorie diet. Now, just to put that in perspective, the average diet that an Asian Indian has is about 2,500 calories. And if you were at the gala dinner yesterday, it was probably close to 3,500. Right? So that is the average number of calories that we take in a day. So moving to 600 is no joke. That means you're drinking liquid meal replacers every day for a period of 3 months. So that's not easy. So in this study, it was for 8 weeks that they gave them the liquid, and then they looked at hepatic glucose output, peripheral insulin sensitivity, pancreatic and liver triacylglycerol levels. So what did they see? First graph, look at the sugar, came zooming down. Week 1 stayed down. What happened to the fat in the liver? Came down. Fat in pancreas came down. Insulin sensitivity improved beautifully, and insulin secretion also improved. So the red line there is control. So you reached actually even equal to or better than control. So what did they say? Liquid diet worked, diabetes levels, the sugars came down, stayed down. Now then they went to counterbalance and they said, okay, 8 weeks is not enough. We need to move this to 6 months. So they did the first 8-week thingy, but they did it in 2 ways now. They took people with low duration, less than 4 years diabetes, and large duration, more than 8 years diabetes, and did the same thing. They did first 8-week liquid, then they still went into, they made it solid, but it was still only 600, 800 calories, very low. What happened here? Results, weight, first is weight. Weight came down, long duration, short duration, you eat 600 calories, your weight's gonna come down. Okay, so that happened. But did sugars come down? Next panel here. So short duration in green, sugars did come down for short duration diabetes, less than 4 years, new onset, okay? But in longer duration diabetes, there's 3 kinds of people. Look at the dotted white lines. The first kind, yes, the sugar came down, stayed down, just like short duration. But then you had the other group of people who were kind of slowly struggling to move, and it's moving slowly. And then you have the kind of people who just never came down. Okay, so we had 3 types of people in this, and this is what counterbalance showed. We then went to US, the direct trial, more number of people, hundreds now, and 24 months intervention. What did these people show? They showed that you can reverse diabetes, but this was directly proportional to the amount of weight you lost. If you lost a minimum of 10 kilograms, then maybe it is possible to reverse diabetes. But the minute you regained any of this weight, the diabetes came back. So that was what came out from the direct trial. But all these were very recent trials. Last week, we were very pleasantly surprised, and we have to thank Dr. Navneet Wada for this. But they found a publication of Dr. Mohan, my dad, which was done in 1986. 86. Okay, much before anyone was talking about reversal of diabetes itself. And there they had found that in 45 Indians, we had reversed diabetes through diet control. Okay, and this is not related to weight loss. Of course, those who are obese reversed easier, but even with 2 to 3 kilograms of weight loss in thin individuals, it was possible to show. So that far ago, we had gone. However, our evidence is limited, and if I told this group now, everybody, let's reverse diabetes, let's get thin, let's drink liquid 600 kilocalorie diet for 3 months. Okay, do I have many hands going up in agreement to say, yes, I'll do it, yes, I'll do it? Yeah, who's going to agree? We may have one or two, but in a large population, we are 1 billion people. How many diabetics do we have? We have 75 million people with diabetes. Can we tell them all to go on to liquid diet? It's not working. In India, we have social and different, everything in our culture is related to food. Okay, we have birth, we have food, death, we have food, puja, we have food, celebration, we have food, Diwali is food, everything is related to food in our culture, right? So it's very hard to go and remove this from a population like India. We also have no population level food choices. We can't do very, very drastic things that will then kind of re-reverse and not sustainable. So we needed something for India. We started looking at many databases, the NSSO, NNMB, NFHS. We didn't find anything that was useful. So we went to the ICMR INDIAB study. Now this is a national study funded by the Indian Council of Medical Research, Department of Health Research, Government of India. And we tried to look at what macronutrient combination in the diet will help for remission and prevention of diabetes in our population. What did we do? We had about 1 lakh population in the study, urban-rural split according, it's very similar to census. We had in every 5th participant, we had detailed dietary FFQs. So after removing all the outliers and people with known diabetes, we then had 18,000 individuals, almost 19,000, in whom we could analyze the dietary data. If you look, it's an almost equal split by sex, and the urban-rural difference is exactly, INDIAB sits on the census data exactly. So this is what we did. I don't expect, I would like, disclaimer, I'm not a statistician at all or a mathematician. I'm a very simple diabetologist. I do not understand complex regression models. So, but very simply to tell you, this was done by Dr. Sheshadri in Kalasalingam University. So just to tell you simply what he did, he took all of this data, okay, and he had this 18, 19,000 individuals, divided them into 3 categories, NGT, pre-diabetes, diabetes. Okay, now what do we do with them? For those with diabetes and pre-diabetes, we look at regression, right, or remission. For those with NGT and also those with pre-diabetes, we look at also prevention of progression. So there are 4 categories, 2 that are reversing and 2 that are preventing progression, with pre-diabetes being in both, because it can move both ways. And then you look at it by urban, rural, gender, activity level, BMI, age, etc. So this is called, an optimization program, and that is the regression model. So you adjust for everything else other than the macronutrient, which is carbohydrate, fat, protein. Other than that, you adjust for everything else. And the question you're asking is, what combination of macronutrients will push at least 80% of the population from new onset diabetes back to remission, defined as an A1C of less than 6.5%. And for pre-diabetes, it's less than 5.6%. So that's how the definition works, and then you get a whole lot of macronutrient recommendations. So this is what it is. The current intake in the population, everything we eat is carbohydrate. 60-70% is carbohydrate. Then there's protein at 12%, fat is 25%, and fiber is about 3%. What should it be for remission for new onset diabetes? First column. For diabetes, remember, it's about 50% carbohydrate alone if you have new onset diabetes. Protein must go up to about 20%. Fat intake is okay where it is at about 25-26%. And fiber needs to be doubling from 3 to 6%. Okay, so this is for remission of diabetes at a population level, the macronutrient intake primarily. Now, I just want to stress here 1 second. If you decrease carbohydrate, there's only carbohydrate, fat, and protein, right? So if you decrease carbohydrate, it's not important just to decrease that alone, but also to increase the protein. Because what happens if you decrease carb, the next thing you're eating is fat. Okay, so be aware that dietary fat should not go up, and the only way you can do that is by increasing the protein content so that fat stays where it is. Remember, 20% protein is what you need. Now, what about if you have pre-diabetes? A little bit more allowance is given. 55% carbohydrate, protein, fat, and fiber stay where they are. Now, this, of course, differs by urban and rural, active, inactive, etc., wherein if you're in the rural area, little more allowance is given. If you're an active person, you're allowed more carbohydrate. If you're a man, you're allowed a little more carbohydrate. If you're younger, a little more allowance is given. And similarly, if you have your normal BMI, a little more allowance is given. So all this is common sense, and that's what will come in the recommendations as well. Now, what about for pre-diabetes? It's pretty much the same. It's at one step higher level with leeways moving just according to how I said. Rural areas, little better, activity, men, younger individuals, etc. But overall, the recommendations don't move by many percentage points. So you may ask, just a 1% difference between men and women, between urban and rural. But here we're talking about 1 or 2% of an entire population. Okay, so that in a population of 1 billion translates to a huge degree of differences when you put it across for an individual person. So all this was about remission. What about prevention of progression? Again, there are two groups, those with normal glucose tolerance and those with pre-diabetes. For those with normal glucose tolerance, and that's the second panel there, you'll see that up to 60% carbohydrate, these are normals. Okay, so in a normal person, up to 60% carbohydrate in our diet is acceptable. Protein, push the protein up 17%. Fat, see that it's not crossing 25%. Fiber stays at 6%, and this fiber is very, very important. It's not at all a part of our diet, so that is how we see that we get it in. For pre-diabetes, little lower, you have to be slightly more strict. Protein again is at 20, and the rest stays the same. So, I'd like to conclude by saying that for the first time, we have population-based approaches for remission and prevention of progression. We're looking at decrease in overall carb calories and increasing the protein. So what we do, the recommendations make our common sense truthfully, okay, but doing this and keeping this for a long period. Now, I have not told you to go onto an 800 kilocalorie diet. I haven't said do this for 3 months and stop doing it. What I'm trying to say is start making small changes in diet for a large period of time, and that is what is going to give us overall health, sustainability, and prevention of NCD. Thank you.
Thanks, Dr. R.M. Anjana, for compensating by finishing it early so that we can remain in time for lunch, as Bansi wanted it to be. I think... Pardon? Please, go ahead, madam.
When the INDAP study, could you see the clusters that Dr. Mohan talks about, that mild age-related diabetes, does that reverse, or the severe insulin resistant and deficient diabetes, so, or only insulin resistance? Can you correlate that among the clusters, those who reversed or those who did not?
Yes, so that's a really good question, and I think a very important one. So among the, we haven't done it, and I don't have the data in terms, but from the overall analyses that we did, the people who reverse have either increase in body fat. So the insulin deficient variety classically doesn't reverse. So if you have C-peptides that are very, very low, and brittle diabetes, severe insulin deficiency, or combined, those are not the types that are going to reverse. MARD will reverse, you're right, and IROD will reverse. In fact, IROD is the better one because they're younger. So if your younger age, biological age is younger, your diabetes age is younger, your C-peptide is good, there is body fat and an unhealthy ratio, those are the ones that are going to reverse easily. So this is not for everyone. Yes, weight can come down, but remember there was a group of people I showed you early on who will simply not come down, no matter what you do. Sugars won't come down. Those are all the ones with severe insulin deficiency.
So probably it is only the IROD group is going to reverse.
No, MARD, IROD,
But
and some.
MARD is otherwise also is a mild age-related
so it's easy to
diabetes,
reverse.
something which is, yes, it is easily
Yeah.
reversible, but
Yeah.
still at the age of 60 or 65, if
Yeah.
somebody develops a diabetes,
Yeah.
why you want to reverse? You may give still the medicine
That
which can
is a-
be for next 20 years is fine with
I
the
don't
otherwise.
agree. I don't agree. Age is a number. At 65, people are wondering whether they should get married. So they definitely would like to reverse their
Okay, that's
diabetes.
fine. The second is related to the SGLT2 inhibitor.
Yes.
Like we know, this is the debates now, it's going on everywhere, that SGLT2 inhibitor for everyone. Now,
Yes.
if you see the sub-classification, SID definitely will not come in that picture. It will be the IROD,
Yes.
or maybe again your MARD, but the thing is with the age-related diabetes, why you want to give more side effects to those who are already having some or other issues
Yeah.
maybe related. Otherwise, your SID, which will not be combined insulin resistant with insulin deficiency. So in a type 2 diabetes population also, only 25% of the patient ideally get, they should get the SGLT2 or GLP-1 analog, which is the ideal most. Even though we say that if established cardiovascular disease, not for diabetes control, maybe for cardiovascular protection, you can give to them.
So you're asking about drug response inside.
Not the data we may not have. This
Yeah.
is just what clinically
So,
we think.
yeah, true. That makes clinical sense. So just to let you know, sir, there is an RCT going on of drug response. I think Dad mentioned that to you, of drug response in clusters, and this is typically the question we're asking. So giving metformin to everybody is not the solution, especially if, and all our guidelines say what? Start with metformin, right? All our guidelines say start with lifestyle. That may not be the case in everyone. It's a very good point you make. So especially in categories like SID, it may not be the drug of choice. Neither may be SGLT2. However, the combined group is there. And such people may need early onset SGLT2 with combination of maybe a DPP4. We don't know. So we're now looking at whether those kinds of drug response, the RCT is ongoing. So maybe in another 6 months-ish, we
But
will have data.
The same group, the CIR, which
Yes.
is combined insulin resistance with insulin
Yes.
deficiency, probably they may also get help from sulfonylurea also.
No,
This
that's
is
what
the
I'm
place
saying.
where
So that's where
sulfonylurea.
the combination of the DPP4
Yes.
with the SGLT2 comes. So that's what the trial is about. We're looking at early combination to see whether that is more effective in prevention of, because we know that they progress to both retinopathy and nephropathy. So looking at whether that combination will help in the progression of the microvascular disease.
Thank you.
Anjana,
Yes, sir.
most of the Indian studies have, especially with Dr. Anup Mishra, has shown that around 67 to 70% Indian population is sarcopenic. They are protein deficiency. And our own
Yeah.
paper, Macronutrient
Yeah.
and Diabetes
Yeah.
Care, they have already shown that reduce the carbohydrate and increase protein.
Yeah.
Why not increase proteins to a 30%? That is one question. That is not a full question now. In rural India, and especially the poor people, it is very difficult to get the good proteins. So, I mean, there is a contrast. We have to increase the proteins in our population. Simultaneously, the most of the people cannot afford the proteins. Carbs is very easily available.
Yeah.
So,
I think you answered your own question. So, so the reason that 30%, we can make it anything, but the ability to consume 30% protein, it's a lot of protein. You can't eat that much of protein. So right now, where are we? We're at 7, 10-ish. So we're talking about a doubling of current level of protein, which is in itself hard for a vegetarian. Now, bioavailability, if you're eating non-vegetarian food, is easier. Now, when you talk to vegetarians, you have to be eating a lot of protein to reach even 20. It's not feasible to eat that much protein and make it 30, and whether that has any additional benefit, we do not know. So we are getting maximum benefit at 20, which in itself is a stretch, and everyone at least should try for that.
Yeah.
But making a guideline that's not, yeah, it doesn't have any additional. 20 itself is hard. 20 itself is hard. Yeah. Yeah.
Hello, Dr. Anjana. This is Dr. Arvinder Singhal. I run a digital therapeutics company named Fitafly.
Yes.
And when we started working on diabetes remission, we promoted 850 kilocalorie diets, and it was unsustainable. Very difficult to do. But what we realized, and we tracked very extensive nutrition, and what we realized is exactly what you said. Average Indian is consuming, in at least in a cohort of last 5,000 patients, about 66% carbohydrates. The moment you make it about 57, 58%, about 7% reduction in carbohydrates,
You will reverse.
leads to an average reduction of 12% of TIR improvement, within 1 week. And this is data which we presented at ADA.
Yeah.
And the moment you start bringing down the carbohydrates to around 50%,
Yeah.
lot of people within 5 years of diabetes, BMI more than 25,
Yeah.
they go into a remission.
Yeah.
And we hate the term reversal because I'm a doctor. I know that, reversal is not the right word, remission is the right word. But interesting thing which we saw, it is not the quantity of calories, it is the ratio. So we call it the delta carb ratio, delta
Yeah.
carbohydrate to protein and delta carbohydrate
Especially in a diabetic.
and fiber.
Yes.
The moment you improve those and couple with muscle maintenance, which is yoga
Yeah.
and exercise,
Yeah.
and better sleep,
Yeah.
so that leads to remission.
Yeah, so sir was asking about sarcopenia. I agree with you, and that's precisely what we're showing.
Most
is
of the
that-
Indians just go for a walk. Even
Yeah.
if they do little bit of muscle
Yeah.
building, the
I
insulin
agree.
resistance comes down,
Yeah.
they feel fitter, better. And
Yeah.
my dad is like diabetic for now 35 years. And I asked him to go for a walk post-meal, showed him on CGM how it impacts post-meal
Yeah.
blood sugars.
Yeah.
Now he's gymming also, he's going to gym, and his diabetic medications
Absolutely.
after 35 years are 50% down.
Absolutely.
Thank you.
Sir, I was going
Thank
to
you,
answer
Dr.
your question.
Anjana.
Yeah.
And in the interest of time, I think we'll have to wind up the lecture.
Right?
One question, madam. Already we know that when at the diagnosis of diabetes, 50% beta cell is lost.
Yes.
So if we lose the 10% of the basic body weight,
Yeah.
it reduces.
Yes.
So what could be the cause of remission of diabetes? Is there any improvement
Sir,
in
there
beta
is-
cell function?
Yes.
Or is
It's both, sir. So what happens, why do you get diabetes? There is fat sitting on the pancreas. Even small 5-gram fat sitting on the pancreas is enough to impair beta cell function. So what happens when you do these kind of diets and kind of reverse, the fat goes away. They showed in the counterpoint study, the fat sitting on the pancreas starts melting away. So even if 5 becomes 4, 4 becomes 3 grams of fat, or it disappears completely, then your beta cell function picks up. So that is one mechanism in which we are able to reverse diabetes. However, those who are severely insulin deficient, that's still a question mark. So we don't know about that. So that's-
Madam, insulin sensitivity will not improve with the loss of weight and all.
It will, sir. They have showed. The
Yeah,
counterpoint I
that's
showed
what I'm
you.
telling you. So
Yeah.
the reason for remission could be an improvement in insulin sensitivity also, right?
Yeah, so he was asking particularly about beta cell. So the fat is everywhere, no, sir. Once it goes away in the muscle and all that, sensitivity will improve. Once it goes away in the pancreas, the secretion will improve. Yeah, the twin cycle hypothesis is exactly about that. Yeah.
I think.
Just quick question. Is there
So,
any-
boss, can you just do it during the lunch session, please? Because we are in lack of time. I'm sorry to both of you. The one who is eager to answer and the one who is eager to question. It's time for me to step down from the stage for the next session to be taken over. Thank you.
Thank you, chairpersons. Now for the next session, I'd like to invite the next chairpersons, Dr. Jayaprakash Sai, consultant diabetologist at Apollo Sagar, Hyderabad, advisor, SAC, and Dr. Myra Kadri. She is working with children living with type 1 diabetes at Diacare. Over to you, chairperson.
Good afternoon, friends. I have great pleasure introducing Dr. Meena, who's a senior consultant at Sri Sir Ganga Ram Hospital, New Delhi. She's a chairman for RSSD Delhi chapter and also chairman for Innovative Physician Forum. And she has received RSSD Award for Excellence in Diabetes Care. And she has a Diabetes India Center declared among the top 40 centers of India for creating awareness about diabetes through various initiatives during the year 2016. Dr. Meena will speak on individualizing diabetes care education for children and teens and young adults with diabetes. Dr. Meena.
So, good morning, everybody. And we switch gears from reversal of diabetes or remission to management of type 1 diabetes. So, can you raise hands? How many of you are actually treating type 1 diabetic patients? Yeah, so there are a lot in the audience. So, this is a very interesting topic because we are talking about management of type 1 and how it differs in the very young patients, so that's up to 12 years, and we could extend it to 14 because there's no clear-cut definition of what is young, what is and adolescent in India, we could include patients between 12 to 18 or maybe 14 to 18. And when I talk about the young adult, I talk about type 1 in age more than 18. So I'm going to talk about challenges in management of type 1 diabetes and how the management differs in 3 different age groups. So living with type 1 is very demanding, and a lot of patients experience psychosocial challenges. Now, patient centricity is important, and individualized care can help reduce stress, improve psychological functioning, and it can improve outcomes. Now, how do we promote patient centricity? Because how do we do it? You have to gauge the education level of the patient, not just the patient, but the parents. Then the healthcare professionals are ill-equipped. Just 3 days back, I think I spoke to a parent very, very nicely and spoke about type 1, and they wrote a nasty letter to me saying that you told our 12-year-old type 1 that she needs insulin for life, and she has been crying because the previous doctor said, start insulin and we'll see. Maybe we are able to stop. So again, it's a challenge. Whether how much do you tell the patient? Do you talk about complications in the first visit? How do you channelize or how do you educate? It's a process, doctors. It's not so simple, but I'll try to make it simpler for all of us. Now, my slides are not moving. Can anybody from the tech team help? My slides are not moving. Meanwhile, I continue to speak. So if you have a young patient less than 12 years diagnosed as type 1 and you're not able to manage type 1, don't treat the not so old type 1 as a miniature. No. Yeah. Don't treat them as a miniature type 2. Please, that's the message which is very clear. Type 1 is a different ball game. If you're not well equipped, you should learn, and learning is a process, but don't burn your fingers by treating very little patients. India, lot of type 1. Now we are going to become the type 1 capital. This is the map showing the type 1. We have very limited data coming from Dr. V. Mohan in the southern part, from Archana Sarda in Aurangabad, and we in Delhi are a part of the YDR, or the Young Diabetes Registry. And we've been seeing increase in the incidence of type 2 in the young, but most of our patients in that age group are type 1. Now, active involvement of people with diabetes and support for self-management. This is very important because care in India is primarily based on economics. So no one type 1 diabetic patient can be managed like another type 1. So you may have a patient who may receive 3 doses of regular and 2 doses of NPH insulin. And then you have patients who can afford more, who may be on analog insulins. Then you may have patients who are not able to check because we are struggling with the sticks, blood sugar testing, equipment is costly. All of us can pitch in. The RSSDI is doing it. We at our individual level can do it by buying sticks at a lower cost by procuring it. Now, diabetes education should be tailored to the education level of their family and the resources available. So you can't tell a patient who doesn't have 2 meals on the plate to test 4 times before every meal and at bedtime, and also take analog insulins. So you'll have to strike a balance. And then you do have a patient who can use a pump. So you have a spectrum of management of type 1, and that's the art of managing a type 1. And never say that the patient is going to be stuck in that category. So today I may have a patient who's on 4 doses of 3 doses of regular insulin and maybe 2 doses of NPH. As the child grows up and gets educated and starts working, we may actually be able to start a continuous subcutaneous insulin infusion and a pump in that patient. So life is not static, and therefore the role of education and the role of hope that yes, today you may not be on the best possible therapy, but yes, when you grow up, study and work, you can be. So I have patients like that who've grown with us, and we've been providing them support, and now they are supporting our young patients. So that's the message again, support children or young people with type 1 diabetes, and they end up supporting your children. So it's like a chain that you build up. So challenges while dealing with the young, lot of psychological, emotional, social, and medical hurdles are there. Young patients' decisions should be made by the parents, but you should involve the child. I have a child as young as 5 years. I'm sure Dr. Anjana and you will have patients who can inject themselves. So as young as 5, and we do have 15-year-olds who refuse, they have needle phobia, and their parents are injecting. So again, it's individualized education. Age and maturity, it's important. We have to train the patient. Now, recognizing patient centricity in young patients, you should recognize that the patient can learn. You should talk to them about blood glucose monitoring, how to inject, how to count carbohydrates. This is important. It's very simple. You can just divide into low carbs, mid carbs, and high carbs. So you can have 30 as low, or less than 30 as low, 30 as mid, and more than 30 as high carbs. Very simple. And also show them a roti and say this has 15 grams of carb. What the patient sees is very easy to understand. So I do have, every month you could call your dietitian to show portion sizes, to say this is a katori of dal, this is one roti which has this much carbs. So seeing is believing, and I think that empowers the patients and their families. So you have to teach them to cope with fluctuating blood glucose levels, and our approach in a type 1 should be quality of life and not glucose-centric. Don't punish the child for one high or punish the child for one low. Now, young children, the biggest concern is feeling like they are a burden on the family. So they keep saying that my father has to spend so much money on my insulin and my sticks. Ma'am, can I test less often? Then another thing that pains them is being treated differently. For example, their mothers keep calling, have you eaten? Even if they have gone for a birthday party. The other thing is sometimes the peers actually ostracize them if they are on a pump, so much so that they don't want to be on the pump because they feel that the pump can be seen by others, particularly in the girls. So they're not allowed sleepovers and outings, picnics. So there's a very delicate balance, and you have to talk to the families. Family can show support to their young children by choosing to eat healthier, enjoying the same food as the child, joining in the child's activities, and just helping to check the child's blood sugar if the child can't check, or at least supervising the numbers so that they don't fudge the numbers. Now, how to talk to a child about type 1? Very interesting. Speak their language. Let them know that it's not their fault. Please explain it's not your fault that your insulin secretion from your pancreas has decreased. Talk to a child in simple terms. Talk to them that the pancreas makes a juice called insulin, like a lemon has insulin. If your eyes are weak, you use a pair of spectacles. If your pancreas are weak, you use insulin. Unfortunately, insulin is available as an injection, but very soon, give them hope. Give them hope that very soon there may be other ways of giving insulin. Other thing you have to do is train the child to become an adolescent. So how do you do that? Call your child with the parents and the adolescent type 1s together in one. Every month I do it, you can call them together. So that is, transition will then become very easy. Now coming to teens and adolescents, move to self-management. They should be taught the skills. They should be taught how to inject. They should be taught how to rotate insulin sites. There's a fine balance between supporting your children to become independent and self-management. So you have a spectrum. There are parents who don't care about the blood sugar and the values, and there are parents who are overly concerned. So you have to strike the right balance. Now, some suggestions to ease your child's move to self-management. Best thing is to empower the child to become independent. So you should allow the child to choose the dose. If the dose is wrong, the pre-meal doses, can use carb counting, or if you are using a correctional dose, you should teach them how to use the maths. So if you teach them how to use a bolus, what kind of bolus is needed, what bolus is needed if you are going for a party, if you are eating cake, that empowers the child, and then the transition becomes easier. So they can make informed decisions. This is what you teach them. Don't give them too much responsibility too soon, but don't be overprotective is what you have to teach your patients. Now, cornerstones we know is healthy eating, physically active, and meal planning. Then, of course, it's important for everyone to eat healthy. The caregiver and the child should be taught about calories, fats, carbs, and, of course, salt. So this is important. Meal planning is important, particularly patients who inject bolus in the morning at 7:30 and in a metro take a 1-hour bus ride to the school, they may need another bolus in the school, and that's where comes the role of the teacher, where the teacher has to be instructed that the type 1 diabetic patient may need another bolus in school at 11 o'clock when he eats with the children. Again, the tiffin should not be grossly different from other students, because then the child feels ostracized. So being active, of course, ADA says we should encourage the type 1 to be active. Now, when do you move from adolescent diabetes to an adult setting? This is difficult because we don't have a transition clinic. Internationally, children are transitioned with a clinic called a young adult with diabetes clinic. So these are different people, but we don't have transition. So some children continue to follow with the pediatric endocrinologist. Some of them continue to follow up with the adult endocrinologist. Now, how are the children's needs different from adolescents and from young adults? Children are compliant. They seek approval. So if you have a good sugar, they want you to say, wow, you've got a good sugar. They, of course, should be taught self-injection, should check blood sugar, and self-inject in school also, may be supervised by the nurse. Adolescence is the problem, which all of you seeing type 1 will agree, that they are the ones, their insulin needs are high, particularly during menstrual cycle. They may have mood swings. They have a lot of parental and societal pressure, particularly class 10th and class 12th, timings for coaching. They sometimes miss their insulin injections. So there comes the role of changing the insulin. We could go to a second generation long-acting insulin where the need to inject every day at the same time may not be there. So you could switch to a more than 24-hour acting basal insulin like a degludec or a U300 glargine, so that the adolescent can have more flexibility. So he can inject at 9 p.m. if he's not going for tuitions, and can inject at 11 p.m. or maybe 12 if he's going for a coaching and he's getting back late. So flexibility in the adolescent. And young adults have a lot of other issues. Biggest issue is jobs. If they don't, they feel guilty about the high costs. Now they're dependent on their parents. So we have to empower them. Girls particularly think about marriage. And if they are getting married, we have to talk to them about contraception and the need to have a good HbA1c before they become pregnant, so that congenital malformations and other complications can be avoided. So this is a job in the young adult that we have to train them for. We have to talk to them and empower them, right? So I tell my girl patients and their families that marriage is not the end of the world. The girl will eventually get married. So I'll quickly go through my slides. Self-management issues also change with age. So when you are younger, it's more important. Peer pressure is important. Going out is important. Picnics. When you are an adolescent, there are different stresses. And when you are a young adult, there are different stresses. So these are the various concerns, and we can address them. And I have been talking about these concerns. And what is burnout? Now, this is an important slide. That diabetes burnout happens is a state of physical and mental exhaustion caused by continuous stress of diabetes and the effort to self-manage it. So they become very difficult, they become non-compliant, they are unmotivated, they may miss insulin doses, quality of life is impacted, and there's a very, very good scale called the PAID scale, and asking just one question, and that paid one score. There's only one question. Do you constantly worry about your future and possibility of serious complications? And if the answer is yes, just one question, it has a concurrent specificity and sensitivity of 80% for the diagnosis of diabetes-related emotional distress. So you should ask this question every time the type 1 comes to your clinic. And if the answer is yes, you understand that the patient is emotionally distressed. Now, many family members want to help, but they don't know how to help. And the majority of family members have not participated in diabetes education. So again, the message is very clear. All of us should go back and at least delegate 1 day in 3 months for education of the young type 1s, the adolescent type 1s, and the young adults who've already gone through this struggle. They are like the caterpillars who struggled and have now become butterflies. So we should use them. So you should form a chain of help, hold hands of the young ones, and then, so that they become healthy adolescents and healthy young adults with type 1 diabetes. So you know the challenges and in an economically underprivileged society, insulins, but you can still manage to arrange insulins through the RSSDI, through other societies. You can actually help your own patients can give insulin. Sometimes my own patients sponsor the other patients. So we have a group like that where one person who's sponsored by me now sponsors another patient. So resource poor setting, education should be continued. Don't just label the patient who has type 1 and is poor that he will not be able to manage his diabetes. Some of them manage diabetes very well with insulin support and a little bit of support of glucose sticks. So education is very important. And how to address psychosocial. I always talk about the 5 Ps. Doctor, I love this slide. And this holistic care by me was enhanced during the COVID time. So we talk about the 5P program where the patient, the physician, the parents, the peers or the friends, the psychologists are all important, and we should have a multidisciplinary team. At least involve the parents, involve the peers, which could be a sibling, which could be another type 1 with diabetes in the management and addressing emotional issues with the type 1. And psychologist is very important. I want to add a 6th P to it, the principal or the teachers of the school. So we must actually give talks on type 1 in the nearby schools. So you can have a 6th P, the principal. So teachers should be sensitized. And we've written a paper on that. These are some of the education, empower and enlighten, some of my own programs. Educated and empowered patients live longer. This is our education and support programs. We talk to the type 1s about storing insulin, the types of insulin. We ask families to ask us questions and seek answers. And we do a point of care HbA1c in the clinic where I ask them to pay whatever they want to pay. So anybody can pay from 50 rupees to 500 depending on what they want to pay. So this is very, very interesting because this way you can manage type 1 better. Then you can have online platforms for teaching your type 1 and their families. It's very simple. You can involve all of them on a particular day. This was my paper in ISPAD, translating rich experiences to evidence, where we found that the teachers were not sensitive. If the child had hyperglycemia and went to the washroom, she thought he was disturbing the class. When the child had severe hyperglycemia and ended up passing urine in his clothes, the whole class ostracized the child, so much so that she refused to go to school. And when we found out and changed her school, she started performing much better. So you have to go to the root cause of all the problems. So this is about sensitizing teachers. Awareness through camps is the answer, because one diabetic learns from the trials and tribulations of another diabetic. So they feel very, attached to each other. So we have these online and offline groups, awareness through camps. These are the various camps. These are my empowered patients. When I started practice, the girls' parents would say, don't tell anybody that my child is type 1. And now we have these 3 girls proudly displaying their sensors. You can actually see the flash glucose monitoring happening in these 3 young empowered girls, engagement with patient. This is me teaching them hands-on how to cook well, what is protein, how much protein, how do you increase your protein, how do you increase it in vegetarians and in non-vegetarians. So my last slide, building a support chain is important. Managing diabetes is more than just writing a prescription like type 2. In type 1, you have to go beyond writing a prescription. It's not about diet, exercise, and drugs. It's about emotional empowerment. And that is the gist, that we should make a chain and support the type 1. Thank you.
Thank you, madam, for an excellent talk. You highlight the importance of diabetes education, empowerment, and self-management skills, and holistic care. If anybody has one question, we'll take one question.
Meena ma'am, I have a question. Meena ma'am. Ma'am, I have a question. It is for the purpose of learning and adopting the best practice. So when we say diabetes education, it covers a lot many things. We have a lot to tell to a family and the patient himself. So I would like to know your comments on comprehensive diabetes care. That how can we study? We cannot tell everything at once, no? So your comments on structured diabetes education program.
I think that's important. structured. I didn't do it because I wanted more like an emotional talk, like an appeal to the audience, and not, throwing my ideas.
How
So
can
I'll
we
tell you,
adopt that?
in the structured thing, you need diabetes educators. So now we are all doing it. There are programs where we are training diabetes educators. I trained one of my own type 1 and then train her to be an educator. So number one is you need a team. You need a nutritionist on the team, you need the physician on the team, and you need a diabetes educator on the team. Also need a psychologist on the team, because like I just told you, the psychologist can actually talk to the patient about what are the concerns. Use the PAID score. We do use the score to ask the patient without using the score that are you, and you'll see the mother sometimes being overly protective. You can find out. So I think structured means you should take 6 sessions. So I normally ask one of my type 1 diabetic patients on Zoom. All my newly diagnosed go to her, connect to her on Zoom, and she charges a very minimal amount of ₹500, and there are 6 sessions. The first one is, what is type 1? Second is insulin, how to store it, how different types of insulins. You may not be able to buy the best today. You will be able to buy when you study transition. It's empowering the patient. Then the third talk is about nutrition. Fourth one about exercise. And the last 2 about whatever questions they have. So this is the way it goes. Structured program. You could train one of your own type 1s to teach on the Zoom platform, and you can join in. So that's my take, that we need to address issues with type 1. If we see a type 1 diabetic patient, it's our moral responsibility to teach them structured program, teach them all these points that I mentioned.
Thank you so much, ma'am. Thank you.
Thank you.
Now it's my pleasure to invite Dr. Meena Mohit ma'am. She is from Manipal Hospital, Jaipur. She is the director of Shaksat Endocrine Center, and she has been mentor to Team India that has won Onsala Cup of ACP 2021. She is pioneer of Cloud Clinic Venture Admits COVID-19. She is editor to MedBTs, reviewer for JAPI, and Mac Miller, founder of Secretary of Metabolic Club Jaipur. She is founder of Women Practitioners Forum, founder member of EMOS and governing council member of RSSDI Rajasthan chapter, and scientific conveyor for Epicon 2022. Ma'am has numerous oral and poster presentation in national and international conferences and numerous publication in indexed national and international journals. She has authored many chapters in the textbook of medicine, and she has been national faculty to API, RSSDI, Diabetes India, Diacon, DIPSI, and she has been co-authored in first ebook of diabetes. Ma'am, over to you.
Thank you so much, ma'am. That was really elaborative and kind for you to go through the entire slide. Thank you very much. A very good morning to all of you. It's still not afternoon, so a very good morning to all of you. After listening to a very exciting and insulting talk from Dr. Meena Chhabra about type 1 diabetes and how do we need to connect and care for type 1 diabetes, I think this is time to actually go to the deep roots of how to do it. She said what to do. I agree with her 100%. But how to do it? In our limited timings, in our resource limited country, we have many challenges. We can talk in such conferences, but I will pick up from the last slide where she talked of connect with them online, connect with them through Zoom. So technology. Corona has given us many bad things, but it has also given us many good things. And one is the best utilization of technology in medicine. So we all know Steve Jobs, right? Apple, the founder of Apple. So Steve Jobs had given a statement that the day you will find intersection of biology and technology, that will be the right utilization of technology. And we are just at that junction today. We are going to talk about how to implement technology skills in medicine, that is type 1 management, and how the life of a type 1 has changed by the technology advancements. So that is about type 1 and technology. Actually, when we talk of diabetes care, for a minute, forget the type 1 in the entire topic and just talk about diabetes care. So it begins with, you have a lot of social interaction. As Dr. Anjana mentioned, we have food as a priority in India. Then we have, of course, the breakthrough in technology that we are facing every day. We have moved from our old cumbersome methods to wireless technology. We all have Wi-Fi's, right? Broadbands. From broadbands, we have moved to Wi-Fi's, Bluetooths. So from wireless technologies, now we are moving to wearables. I can see the Apple Watches in most of the hands. And those Apple Watches give you instant ECGs, your blood pressures, your sugars, and many more things. So we have moved on to wearable technologies. And with that, what are we having? A huge data. So now we have our own Indian data to support everything we are doing. So huge data we have, and that is what we have with our today's technological advancements. So the agenda for my topic will be, do we really need technology in diabetes? If yes, then what are the current technology practices and what is the future? Moving to the need of the hour. So as we know, the burden of diabetes, we are, just yesterday Dr. Shashank mentioned, we are the world capital of type 1 diabetes. So we have a total burden of almost 2 lakh children or more. So we have a huge burden of type 1 diabetes, and as a result, what do we do with these children? We are managing them in terms of managing blood glucose, we are monitoring them, we are administering insulin, and also we are following them up closely. And how is all that possible? If we have the right utilization of technology. So just forget the medicine and just look around. Your phones, they have actually walked a long way. We were having landlines first, then we had those conventional small pagers during our residencies, then we had the mobiles. And you know, the first mobile I purchased with my own stipend, and I hid it inside my cupboard. You know, I didn't tell my parents that I bought a mobile. It was something a taboo. But now it's a show off, the best, the moment. I think most of you must have pre-booked your iPhone 14 already. So the technology has advanced so much. And why we are not using that entire technology in our medicine practice? We are using it everywhere. You know, most of the parents are now giving smartphones to their babies in the, the prams maybe, to the lullables. All the loris are in the mobiles nowadays. So the same mobile, that same technology, same apps can be downloaded, and those apps can be utilized for our blood glucose, not only monitoring, but also transferring the data, following them up closely, and using them for our adequate diabetes management. So what is the scope of the technology? We'll begin with the scope, that is measurement. What is the first step in diabetes management? You need to know the values. And to know the values, you need to measure the blood glucose. And that is, Madam said, we should empower the child to measure the sugars. How do we empower him? By giving him a glucometer and teaching him SMBG, that is self-monitoring of blood glucose. Moving a step further, you can also use sensors. You can make the child complete accommodative with the readers, and the child can just place the reader in front of the sensors and without pricking can know his values. So we can accommodate the child with CGMS or even the FGP, that is a flash glucose monitors. Then comes the education part. As ma'am was repeatedly saying, educate and educate, because education is empowering. My clinic, Sashakt, that is empowering. So the idea is education empowers you. So education, you just don't need to leave your chairs. You don't need to move out of your cabins. Sitting on your own chambers, we are doing webinars. Enough webinars we are doing with our peer groups. Let us connect with our patients on these Zoom webinars. So you can convey your message about diabetes, importance of SMBG, importance of CGMS, how to train the patients in insulin administration. It's very easy to write a prescription. But who knows how to administer the insulin? Sir was talking about, Dr. Arvind sir was talking about prescription errors. I will give you a very interesting example. I sent my patient on 10 units of Novorapid or whatever the insulin may be, and he just injected himself 1 unit and came to me saying, sugars are pretty high. Why? Because he said, 1 unit I thought is equivalent to 10. So he just dialed 1 unit. And now for an adult administering 1 unit, what it will be? Just nothing, it's a placebo. So education is very important. And then comes the next part, that is treatment facilitation. Again, we can use the same technology. Yes, you have to be available for your patients, of course. That same data is transferred to you through on your dashboards. Now most of the apps enable us with our dashboards. So we can use that data to connect to our patients. Then there can be CGMS which are coupled with hypo sensors. There are alarms. As ma'am was saying, we can't play with any pump because pumps can be killers. If there is an entire run out of the insulin, the patient might land up with a hypo. But we have hypo alarms nowadays. So that is one thing which can be taken care of right with your technology. So that is the need for technology. Nowadays, even for, I think, for the sessions, if my phone is with somebody else, I am not comfortable. So we are so adapted and addicted to technology that even if for a one day your Wi-Fi is shut down because of some exam going on in the town or because of some police survey, you are not comfortable with Wi-Fi. When will the Wi-Fi get connected again? So we are so addicted to technology. So the need of technology is well established. Then moving to what is the current technology in medicine. Who all are very well aware with this? We all are, I believe. We all started from here. The urine dipping, then matching, that color coding. So that was the time. Now how many times you think we can tell a type 1 child, go to the loo, get your urine sample, dip a stick and find out what are your sugars. Hardly we are doing that anymore. So what are we doing now? We are giving them glucometers. And the glucometer also, if you remember the first glucometer, I gifted to my father, it was this big. And thanks to the technology, today we have a very beautiful device, fancy device, which can get connected directly to your mobiles rather. So that is thanks to technology again. We are having chips, the microsensors, and the technology is MEMS, that is the microsensors, micro actuators, we have microelectronics, and we have microstructures. And that micro has given us mega benefits. And this micro converted into our mega benefits has transformed our diabetes management for our type 1 as well as type 2. So, as going back to Dr. Meena Chhabra, your patients, you want to help them? Give them the power of SMBG, give them the power of CGMS, give them the power of education through your Zoom networks, your webinars, your online platforms, connect with them, teach them, and stay connected with them. So the advantages of glucometers, of course, they are very handy, portable. We can, some of us maybe even carrying right now in our purses. So they are very advantageous. See, you can't find a coin without two faces. That's acceptable. We don't have any coin with two faces. So of course, they also come with their own disadvantages. There is a challenge with accuracy. So they need calibration. They need standardization. So we need some standard and reputed companies to come up with standard glucometers. So we don't recommend any and every company, of course. But the glucometers are a big advantage. Then the SMBG. SMBG is self-monitoring of blood glucose, and it goes without saying that SMBG is only possible because of the glucometers. From glucometers, we have moved to sensors, CGMS, flash glucose monitors, and we have enough data that such data is not only written by the patient, preserved by the patient, but the same data is now shared. And when it comes to sharing, it is not only sharing with your physician or with your doctor. The same data at just one click goes to your relatives, your friends, your family. If suppose the old parents are living alone far away in your native and the children are working somewhere else, they even get an alert that your father or mother or your parents, somebody or even your child has gone into a hypo, and they can send help right across. So technology has really helped us a lot in managing diabetes, and we can really do our jobs in peace of mind, with peace of mind. So moving from the glucometers, as I was talking, we are now having smart glucometers or smart meters, where we have even the storage pockets where you can keep your extra strips. Then you have your device, you can even keep your lancets. You can also have small clips. You can see, you can just connect it to your smartphones. So you don't even need to have a display chamber. You don't need to have a glucometer with you. You just need to have your smart meter. Now there is a meter magic. So this meter magic is again based on the CCM technology. This will give you a very accurate reading. Also keep your data stored, transfer your data to your physician and your family, and also maybe guide you as what next step you need to take, whether you need to take some glucose or you need to take some insulin. So the meters might even work as your temporary transient physician. Now the things are getting more convenient as we move from technology, advancement of technology. Your phones are also coming with USB devices, USB data. So you can even transfer your data from one device to the other. They are all paired easily. And for children, type 1, this is very interesting. They're even coming with game consoles. You can use the strip console here in your game. The child is playing. He's busy with that Pokemon maybe, or some Ash or something. They keep on playing, and then you can just put a strip there and just check a sugar, and it's done. Then as somebody was talking about the tattoos, we have temporary tattoos now. So you can see the tattoos here. They are temporary tattoos. You don't need to prick every time. These tattoos, they keep guessing the sugars, and they transfer the data to your display machines, whichever you have paired them with. So they are the diabetic temporary tattoos available. I have 5 more minutes. Okay. Then CGMS, of course, the CGMS gives you a closed loop. You can couple it with your sensors, and the data is transferred from your sensors to your pumps. The flash glucose monitors, which have made it very economical further. Now we have the 15-day sensors with us. We even have the longer sensors, but in India we do not have it. So we have the real-time data also available now with these sensors and these flash glucose monitors. Another advancement of technology which has really made life easy is doing away with this vial and syringe business. What we need to do is the pairing of that 40 IU with 40 IU vial, 100 IU with 100 IU needle, and most of the time we are making errors. And that is done away with. We now have very smart pens. We even have pens which will tell you the dose, how much insulin is left in the cartridge. All those data is given with your smart pens. You also have the readers, you can see, and these are the pumps. So we have the delivery device advancements. Inhalational insulins, yes, they were there in the market for some time, but sorry, it did not work out, they were withdrawn, but soon we will have them again. And with the peptide in a pill, oral semaglutide, we are very hopeful we might have oral insulins also. Then, of course, we have something like the tooth concept, which I will just talk to you. The inhalational insulins have been withdrawn, and the lack of time is not allowing me to go into the depth of it. Then we have the nano pumps coming up, again with the MEMS technology, that is the micro SIMS, microstructures, micro actuators, and the micro technology. Beta cell encapsulation, the stem cell transplants, we still are not successful. And the reason being, there are antibodies, and those antibodies, they attack whatever the transplant is done. So to bypass those antibodies, we have a new technology, and that is beta cell encapsulation. Now we are encapsulating the beta cells, and this encapsulation prevents them from being attacked by the antibodies. And we can combine it with immunotherapy, and that will help us probably in overcoming our type 1 diabetics, and we might end up with cure, not with care. We can even start talking of cure of type 1, because there has been a vision of setting the world free of type 1. Then, of course, the artificial pancreas, the bionic pancreas, there is advancement. There was an initial venture with a huge, big pancreas, artificial pump, which did not work out. But now we have very mini chips, which are again the bionic pancreas. You can find here encapsulated beta cells along with a chip which is placed subcute. So coming to your apps again, you may be having hundreds of things. Your kitchens are fancy, but do you really use them ever? You just go and pick that one particular thing which you are used to. The same thing is with your mobiles. You are using that device, you are buying 1.5 lakh device for making a phone call. Phone calls can be made even with your landlines. So use your phone for the best of the technology, download the best of the apps which are available, and get accustomed to them. There are apps like My Sugar, there are apps like Diabetes Buddy, there are apps like Glucose Buddy, there are apps like Diabetes Pal. I'm not going into the details of each app, but they all come with their own speciality. Then we have MedSimple. We have Fitter fitness calculators, which actually tells you your target weight and where you are. Then this is the time, this is the future technology. How do we see our patient? How do we think we will be seeing our patients? I proposed also, Dr. Bansi sir, that we can even have, we want to reach the rural areas, the villages. Let's have the Skype clinics. So we will have Skype clinics. We will be giving an online prescription. We will be seeing patients online, and we will be educating patients online. So sitting in your AC chambers, not subjecting yourself to the hot temperatures of India, you can reach out to the farthest of the village where there is internet available. So you can do that. So that is the future model of diabetes management. Diabetes registry, yes, we are planning to have our own registry very soon. It is going to be probably with us very soon, type 1 registry. The advantages of registry is that, again, we can reach to our total burden. We can plan the total need of the insulin, total need of the glucometers, total need of the glucometer strips, and we can make them available. So the idea is, register your patients, join the registry, so that we actually know the total burden. This is a paper in the NEJM that was published, which is showing the significant benefit of type 1 diabetes management by the utilization of CGMS. So CGMS is going to give us the benefits of type 1 diabetes management. I'll just take half a minute more maybe. So the future technologies, this is the last part of the agenda. The future technology lies with augmented reality. So we have augmented vision, augmented reality. You can use it to find out what will be the sugars without pricking your patients. You have something called the lenses. You have fluorescing implantable capsules, those capsules that keep changing colors as per your blood sugars. So green stands for healthy, red stands for unhealthy. And the intermediate color, they will be just like you were using the color coding for your urine sampling. Now you can use your color coding for your fluorescing capsules. Similarly, you have magnetic glucose sensors. Again, they have pH coding. So when the sugars rise, they become heavy, thick, and when the sugars fall, they become thin. They shrink down. So you can use these magnetic glucose sensors without pricking. Then optical lenses that Dr. Muruganathan mentioned in the morning in his oration, that there are optical lenses. So these lenses are just like soft lenses which are having fluorescing sensors again inside. They are worn by the patient, and the color coding you can see is a hint of green is normal, blue will be hypo, patient is landing into a hypo, and if the color goes violet, it is very hypoglycemic. So just by looking at the color of the eye changes, you can announce that your patient is having a normoglycemia, hyperglycemia, or a hypoglycemia. Then we have the fiber optic sensors that mimic hair. So we have something very thin like a hair which is placed again subcute. So are we ready for the future? Are we ready for the future? Yes, we are. We are ready for the change. We are the generation who has seen the maximum change. We have seen our grandparents with all conventions. We are seeing our children who are far ahead of us probably. So we are the generation who has seen the maximum change, and so we are ready for the change. We are ready for the future technology. Thank you so much. And this is the diffusion model which will tell you that yes, we are ready. So we are here at the blue zone. We are the most pragmatic generation, and we are ready for the future management of type 1 diabetes. Thank you so much.
Thank you so much, ma'am, for putting it so well from past to the future of diabetes technology. Thank you.
My query is alarms available, DESCOM, you said alarms are available. The flash glucose monitors, no alarms.
The CGM has the alarms, the Medtronics one.
Libre 2, which is now available.
The Libre 2 is coming with the alarm.
Already have the alarm. It is now showing the similar thing, the way it is shown.
Libre 2 has the alarm. The Libre and the Libre Pro did not have it. Yeah. Thank you so much.
I have an announcement to make. There's a blue Baleno parked at the front of the gate. So if the owner is here, the car number is 5777. Please look into the matter. It is 5777 blue Baleno.
I have great pleasure introducing my good friend Dr. Rutul, who is a managing director for AHC Diabetes Center and is also governing council member for DIPSI, national coordinator for D-Genius Group of Diabetes India, and also organizer for Dia Connect Diabetes and Pregnancy Conference. Dr. Rutul will speak on what are the tips for a successful type 1 diabetes management? Dr. Rutul.
Thank you very much, sir, for kind introduction. And it is really unfortunate that we don't have Archana Sada today with us, as she is not well. And I'm very fortunate that I'm presenting her talk because I really closely follow her work in type 1 diabetes. And if you are really passionate about type 1 diabetes, you should once visit her center. And I have been there. Bansi Sabu sir may have visited her. Dr. Mahira has also visited her. So how to empower the patient, how to motivate them, it is really astonishing her work and to see her very closely and to know about her. So my today's topic is tips to successful care in type 1 diabetes. But before starting that, I want to tell you that I shared one of the recent incident of type 1 diabetes and pregnancy with Bansi Sabu sir, that what not to do is very important. Sometimes we forget. And one of my type 1 diabetic patient, I got the call from ICU, and gynecologist referred me that patient and told me that she is in DK. She was 7th month pregnant, and she was in DK, and that was third time that she was admitted. The patient was from Surat, and she was referred in Ahmedabad ICU just because her blood sugars were not in good control. She was already on 150 units of bolus insulin, and there was no basal insulin. That was quite surprise for me, and it was not a small city or rural area. It was from Surat. So it should be basal bolus therapy. I don't know, God is protecting or whatever is there, but that patient did not have a single complication, even to her fetus, and that was really fortunate from our part. So for type 1, at least we should learn that patient should be on basal bolus therapy. The basal insulin is very important to avoid the condition of diabetic ketoacidosis, and that we all need to learn all the time. With this, I'll start talk of Dr. Archana Sada. Even I didn't change her name, as I don't want to take away her name and her slides and her work. So it's an art and a science that you need to learn, that art of treating type 1. And sometimes that art can't be learned because it is something related to your empathy and your passion for type 1 diabetes work. So education, motivation, and counseling that is related to insulin technology and regime pumps and CGMS and carb counting. This all stuff are really difficult to educate to those rural patients. Even in our urban areas, most of the patients, many of the things we can make them learn, like insulin and carb, insulin and pumps and CGMS, but carb counting and the correction factor, this all stuff are really very difficult to make them understand. So approach to type 1 diabetes care, where, as I already told, empathy lies the first. If you are really passionate about type 1 diabetes, then only you can work, and you should work. Otherwise, you should refer the patient who are really treating type 1 diabetes, and every day they are seeing, or at least once in a week, they are spending time for type 1 diabetes. So this is very important. Engagement to your patients, your parents of your patients is also very important. And the empowerment, already Dr. Meena Chabra ma'am has explained what is empowering to your patient. It is all about education. So individualization of care is also very important. Every patient has different problem. Like some patient has problem in buying insulin. Some patient has problem in buying costlier insulin. That we need to understand mindset of patient as well as their socio-economic status of the patient. Monitoring, already Dr. Meenal Mohit has explained monitoring, how it is important. She explained how SMBG, CGMS are there in the role, and how we can change the patient's life through good monitoring. Physical activity, the most neglected part, I would say. If you, I've really seen, we don't have data for our center, but I can say that around 70 to 80% of our patients, they don't follow our physical activity guidelines, or they don't follow whatever we say. But for type 1 kids, unfortunate part, we can say that, yes, they go to play outside in kindergarten and everywhere. So somewhere they do some physical activity. But for adult type 1 diabetic cases, it is not followed mostly. Follow-up and investigations. We should have structured follow-up plan, and we should ask them on what date they have to come, and investigations. That also we need to explain them. At least HbA1c should be done every third month. Yesterday only, when I went to one of trust where I go for type 1 diabetic kids treatment, and they said that one of the patient came, and she came after 2 years of follow-up, and she didn't even check her HbA1c. She came up with a logbook which was really forged. In her logbook, every data was around 100 and 150, and I just came to know that it is not possible that you don't follow up for 2 years and your blood sugar is not going above 200. So I asked her in front of her parent, her mother, that did you forge this data? And she accepted, yes, I do some wrong thing in my logbook. So it is very common, and you all must have experienced one or other day that your patient is doing something wrong in their logbook. So HbA1c is important for this reason. Maybe 3 months, not possible in 3 months, then at least in 5 to 6 months, they should have one HbA1c. So emergency care should also be provided. As we have learned from Bansi sir, that we manage decay in daycare settings. Most of our decay are treated in daycare settings. So we call them for 1 day. If their acetone is coming down, then we call them again to second day, and we treat them in 2 to 3 days. This is our type of treating decay. And most of the cases, they don't need ICUs. So medical nutrition therapy, this is also one of the very important pillar, but it is also unfortunately not followed very well. So that also should be taken care, and individualization of care is important. This is why. So creating a team, already Meena Chhabra ma'am has already explained that educators, counselors, leaders with type 1 diabetes, coach, nutritionist, and the one thing here it is not mentioned is psychologist, which is also very important. But RSSDI and Diabetes India has taken very good step that they have made leaders in type 1 diabetes, and those leaders are taking care of those patients, their parents, and they have made the team, and these leaders are working beautifully 24/7 for type 1 diabetes management, and they are helping a lot. So maintaining an inter-visit communication channel that are helplines, WA group, sorry, I don't know what is WA group, anyone? WhatsApp group, okay. So I could not ask Archana ma'am what is that. But yes, we have WhatsApp groups for our type 1 diabetic kids. Call your buddy, online meets, and social media. We know that Archana ma'am is doing wonderful job in online and social media meets, and we are also part of those meets regularly. And it is helping our patients and parents, especially caregivers, very beautifully. So maintaining documentations, registration, investigations, and clinical part or the treatment part, it is also very important. And we are seeing that documentation of type 1 diabetes is very poor, though there are many registries like SWEET, and many of our doctors are part of it, but we want our own registry of type 1 diabetes, and RSSDI is working on type 1 diabetes registry, and hopefully it will be done within next 6 to 8 months, right, sir? So let's all join together for type 1 diabetes registry. So focus on first month is very important for newly diagnosed type 1 diabetic patient. A new family is really vulnerable. They are traumatized and blood sugar fluctuate and doses are not yet settled. And you might be seeing them taking opinions of a different part of medicine, alternate medicine. And it is very unfortunate, as many of the patients, when they go into honeymoon phase, they think that this is the reversal of type 1 diabetes. The reversal of type 1 diabetes is not possible. And we are seeing through alternate medicine that many of doctors, they are claiming that type 1 diabetes also can be reversed after a few years or few months. And we need to educate them that type 1 diabetes is your friend for life. And busting myths around type 1 diabetes is important for this reason. Addressing possible honeymoon phase, emphasis on insulin always. You can't stop your insulin, especially your basal insulin. You should not ever stop your basal insulin. If you really want to avoid decay, never stop basal insulin. There should not be any excuse for stopping insulin. Warning against fraud, alternate therapy, perfecting insulin and monitoring techniques, learning to manage hypoglycemia. I would say hypoglycemia is one of the really rate limiting factor in type 1 diabetes management and good glycemic control, because whenever type 1 kid gets hypoglycemia, they tend to eat a sweet, and it becomes a habit of eating sugar, just because they really want to land into hypoglycemia, and they get the chance to eat the sweet. So looking out for comorbidities and individualization of treatment is also very important, and this is how hand-holding can be promoted. Insulin regimes, I am not going very deep, as this August audience don't need this introduction of all the insulins, as they all know. But insulin regimens, for that, ma'am has beautifully structured here options for all. We should check those options. Then no premix insulin, please. I want this orange or red thing to be amber and not orange or red. And the last one, insulin pump for all those who can, should be green one. That should be a suggestion just for this PPT. So monitoring and logging. Though all the guidelines suggest that at least 3 to 4 times in a day your blood sugar should be checked, but ma'am has beautifully shown this slide that we should ask the patient to check at least two times, 2 to 3 times in a week, then one day you should check for six times. CGMS, already Minal Mohit ma'am has talked, and it should be tried at least once in a 3 months or a 6 months. It depends on patient, how affording it is. This is the patient of Archana ma'am who is on insulin pump. She is aged around 4 to 5 years, but I guess Medtronic pump of 780G is allowed after 6 years of age. But I have also a few of the patients whom I have tried insulin pump before 6 years of age, if the patient takes care of those insulin pump well. So nutrition part, a balanced plate, identify macros and visual carb counting, and carb counting is very important. But I'm not going into detail, but this is part of our nutritionists, and they should take it as good as it is possible. So self-meal planning is advisable, and every family can learn to eat healthy. So this is the patient of a very rural area from Aurangabad, that ma'am has shown this photo in last one of the meeting before 2 months as well. Yes, Sambhaji Nagar. Now it is Aurangabad, Sambhaji Nagar, yes. So she already explained this patient that what is importance of carb counting, and she is doing her on her own. She is around 8 years old, and she is doing it beautifully. So every patient can be explained. It doesn't matter whether she is from any rural part of the area. So follow-up, use ISPAD, ISP and RSSDI, or make your own protocol of follow-up. Whichever way, a regular structured follow-up and screening is must. And we all know that what reports to be done in type 1 diabetes regularly and annually. So these are few photos how she does her educational work or awareness programs regularly, and her this awareness programs mainly are on every Saturday. So education and its tools, every family with type 1 diabetes can be and must be educated irrespective of literacy status, and we already see one example. And these are few the games. By those games, she explained her type 1 diabetes kids how to manage type 1 diabetes with the games. And this is a unique kind of earthen pot that she has made, and this earthen pot can be made with 50 or 70 rupees, and it can take care of those rural kids who don't have privilege to have a refrigerator at their home. So peer group activity, it is very important. So they should feel that I'm not alone. They should see all other different patients, how they are taking care. They should be invited to different camps and educational activities. If they can do it, then I can do it. Sharing and learning should be advocated. Social acceptance, psychological acceptance, and experimental learning should also be there, and introduce new people with type 1 diabetes to experience champions. Leaders with type 1 diabetes make motivating educators. So these are few pictures of her patient. So it is still easier said than done. Always we need to do more and more for type 1 diabetes. It is always undone. And that is how easy diabetes data software is to use. Any questions? So let us do it together. Every child with type 1 diabetes deserve to thrive in their life. With this, I'll conclude my talk, and if we have any question, we have Meena Chabra ma'am and Dr. Meenal Mohit if she's around.
Thank you, Dr. Rutul.
Thank you very much.
For covering excellent talk. We all admire Dr. Archana Sharada for her passionate work in type 1 diabetes care in our country. We'll close the session. Thank you.
Thank you, chairpersons. Now, for the next lectures on state of arts, I would like to invite the chairpersons, Dr. Urvi Parekh. She's a diabetologist from Ahmedabad, and Dr. Rohan Patel, consultant diabetologist from Bharuch. We have a change in the first speaker, chairpersons, if you have been notified. Over to you, chairpersons.
So, good afternoon. Now, moving to the last session for the day, we do have the first speaker today, Dr. Pankaj N. Surange. Sir is have done the MBBS from GR Medical College, Gwalior. He is MD Anesthesiology from RB Base Hospital, New Delhi. Sir has also have fellowship International Pain Practice, Budapest, Hungary. Fellow Indian Academy of Pain Management, as well as the fellowship of Spine Endoscopy from Korea and Germany. He is the director of Interventional Pain and Spine Center, New Delhi, and as well as the director of IPS Indian Training Institute. And he has been Honorable Secretary to Indian Society of Study of Pain, ex-chairman of World Institute of Pain, founder, member and treasurer of Musculoskeletal Ultrasound Society of India, And sir has been invited as a faculty at various national and international conferences and many publications to his names, even with the book chapters. And sir has been recipient of Pain Awareness Ambassador Award, Excellence of Pain in Practice Award by World Institute of Pain in 2017, and also the National Pain Physician of the Year Award 2016. So sir is going to give us a talk today on advanced pain and spine interventions. Over to you, sir.
Thank you, Chairperson. So actually, I am actually misfit over here. I came here for some other reason to present in front of the accelerators and the VCs. So that was, I think, it was yesterday, and I came today because I came to know it was today. So this is how it was a misfit. But I'm very thankful to Dr. Sabu and Dr. Amit that they fitted me because there was some, I think, deficiency in one of the speakers. So they fitted me over here. I just thought about at the last moment because I just came to know that I have to present right now. So I thought, what should I present? Whether I should be presenting on the diabetic neuropathy, neuropathic pain. So I thought that it is again, it's not feasible for me to discuss about the neuropathic pain in front of diabetologists because who all are managing the diabetic neuropathy also. So there is no point of discussing the diabetic neuropathy here. So I took this opportunity and I thought that let me just tell you about what is pain medicine, how much we have progressed in the field of this pain medicine. So this is my hospital, IPSC. This is a first of its kind in all over Asia. This is the pain specialty hospital. Here we do end-to-end solution for the pain management. Mainly my focus is on the spine and the joints, so I'll be talking mostly about the spine interventions. So pain medicine, as you all know, that it is not a new specialty. It's been there since last 4 or 5 decades now. ISP, International Association Study of Pain, which was formed in 1973. WIP, World Institute of Pain, it was formed in 1993. Indian Society of Study of Pain, we came in 1986, and today we have around 300,000 members. What is new about the pain medicine in India, that India is the first country all over the world which has given a super specialty status to the pain medicine. Now we had DM in pain medicine, like you have DM in endocrinology. So we also have this DM in pain medicine and post MD fellowship programs by National Board of Examination. So MIPSI are basically these are the procedures, minimally invasive procedures, what we do for the chronic pain, for the spine, joints, and the neuropathic kinds of pain. Just to give you an idea about what we do, what is the advancement in the pain medicine. If you look at these MRIs, you can see in all the conditions there is some pathology in the disc. So whenever you talk about a disc problem, the first thing which comes into mind is the discectomy or the fixation. That is the first thing which comes into our mind. But what we do as an interventional pain specialist is that we identify the root cause of the pain. So it is not that any patient coming with a disc problem will remove the disc material from there. So we have multiple pathologies in the spine. It is not always the disc which is the cause of the pain in the back in the spine. The most common is the discogenic pain. The second is the facet arthropathy, sacroiliitis, myofascial pain syndrome. So there are multiple causes of the back pain. It is not always a disc. Disc prolapse as such is just 2 to 5% of the spine patients. So this is what we can do. Like you can see here, there's a big tear in the annulus. So disc is ruptured over here. It is not bulging, it is not protruded, but it is ruptured over here. So this is the most common cause of the disc pain or the spine pain or the chronic back pain these days in the younger population. This is mainly because of the oversitting and the inactivities. So these kind of disc ruptures, we can repair them with the minimally invasive interventions like this. This is called a bicoplasty or the percutaneous annuloplasty. This is how we do it. Like this, we can go in with the radiofrequency techniques. If you have a bulging disc like this, if a hydration is good, we can go for the ozonucleasis. Ozonucleasis basically helps in the shrinkage of the disc. We don't have to remove the part of the disc. We can just shrink it over there only. This is another technique where we can use a decompressor. It's a percutaneous decompressor where we can remove some part of the disc material from the center of the disc, creating a space, and we can reduce the pressure. If you have a very large herniation compressing the disc, or if it is extruded like this, it has come out, or if it is sequestrated that is lying in the canal, in those cases we have to target these fragments which are come out. So for this we can do endoscopic discectomy. So endoscopy is again a very minimally invasive interventional procedure where we can go with the scope and we can remove the disc material from there. So this is how we go with the scope. This is endoscope which goes inside the spine endoscope, and we can remove the nucleus material from the center of the disc. So there are different kind of techniques. I'll not go into the technical details. I'll just show you some of the examples. This is a very large extrusion over here, which is almost compressing the nerve root over there. So this kind of herniations, we can go with the fluoroscopy guidance, and then once we reach our target area under fluoroscopy, then we can put a scope inside, and we can remove the nucleus material from there. So this is through the scope. This is a grasper which I am holding this extruded material over there. So all these procedures we do under local anesthesia. We don't have to give GA or the spinal anesthesia for these patients. These patients can go back same day also. We normally do it in the daycare setting also. So I'll just show you this, how we can remove that extruded material from there. And you can see that this complete disc material has come out, which is extruded over there. So the advantage of these procedures is that we don't have to remove the disc material from the center. We just target a fragment over there. So earlier what we used to do, we used to remove the disc material from there. We used to fix the spine. That is not required now in most of the cases of the disc extrusion. We just had to go with the, you can look at this. There's a extrusion over here. And this is a post-operative case where we have just removed the extruded material from the disc. Spinal cord stimulator is one of the options which is available for the neuropathic pain. This is normally what we are using for the failed back syndrome or the failed surgery syndrome, where we have done multiple pathologies and the patient has come with the neuropathic pain, severe neuropathic pain as a last resort. In these cases, what we do is basically we put a spinal cord. This is a pulse generator which is placed inside the body. Now, these are the leads which are placed over the dorsal column into the epidural space, and the patient has a control of over the pain of his or her own. So this basically pulse generator, this acts on the principle of the gate control theory. So in India, it is not very commonly used for the diabetic neuropathic pain, but yes, in the UK and other countries, in the Western countries, people are using this spinal cord stimulator for the neuropathic pain also. In India, we are using it mainly for the failed back syndrome. So here, what is the advantage of this is that we are not controlling the diabetes, or we are not controlling the neuropathy, but what we are converting is the neuropathic pain into the paresthesia kind of signals. So it basically acts on the principle of the gate control theory. Definitely, we have a huge potential for the neuropathic pain related to diabetes also. As we know that diagnosing the neuropathic pain or the neuropathy in the diabetes is really very difficult in the early stages. Whereas once it is established, we cannot reverse it. It is very difficult to see that reversal happening. Yes, medical management, we can control the symptoms, we may slow the progression of the disease, but obviously the diabetic control is the most important thing which is important. But in failed cases where the medication management is not helping, in those cases we can go for these kind of devices where we can put them implant inside the body. So it's like a pacemaker for the spine only, like what we use the pacemaker for the heart. This is exactly the size of that pacemaker only. The beauty is that patient can control his or her pain. They have a remote control with them. They can switch it on anytime, they can switch it off anytime, or they can increase the current if they have more pain, and they can decrease the current if it is less. Vertical augmentation is one of the procedures which we have seen in a lot of cases where in a chronic diabetic patients which leads to the osteoporosis, and they land up into the osteoporotic compression fractures. So this is what we do nowadays with we don't have to fix these spines, because fixing is a very big challenge with these patients, because they are already osteoporotic, and putting the rods and screws inside the vertebral body is really challenging. So in those cases, we can go with this kind of vertebral augmentation procedure. Now you can see it's an osteoporotic fracture. For this, earlier we used to do this kind of fixation, but this is not required, because we can go with just a small diameter cannula over there, and we can just fix this. You can see there's a big fragment, there's a big cleft over there. So we can just fill those kind of cleft, and we can fix those spines. You can see there's a completely collapsed vertebra over here. This is again an osteoporotic compression fracture over here, and how we can go and selectively do the targeted cementoplasty in these cases. So these kind of osteoporotic fractures, they may come with the multiple fractures. So at 1 level, 2 levels, or 3 level, we can do maximum at 3 level in one go. But if it is more than that, then we have to do it in 2 stages. Spinal pain pump is again a very advanced technology where this technology we are using mainly for the cancer pain patients, not that useful for the neuropathic pain, but yes, definitely it is very good for the somatic kind of pains. Especially the cancer pain and the spasticity. In the patient who is having spasticity, we can fill these pumps inside the body. So this is a pump which we can be fitted inside the body. Now this is connected to the spinal into the thecal space. And this is the catheter. We put it like this. We put a catheter inside. This is a catheter which is attached to the spinal pain pumps. And through this, the medicine goes inside the spinal canal. So this is how we fill the pump with the drug. So these drugs are basically, it comes in the 30 to 40 ml capacity, and what you require is just 0.25 ml of drug every day. So suppose if the patient is already on morphine, 300 milligram of morphine, we just require 0.5 milligram of morphine. So you can see how much difference it makes from 300 to 0.5 milligram. So because if we are directly delivering the drug directly into the thecal space. So this is the advantage of these kind of pumps. Obviously, these are not used for the neuropathic pain, but mainly for the somatic kind of pains. So again, this is fitted. This is a kind of pump we fit inside the body. And once it is fitted inside the body, obviously we cannot control it from outside. We have to refill it. We don't have to take it out. So there is a port over there. We have to just identify in the fluoroscope, and we can just refill it after every 3 months or 6 months, depending on the life expectancy of the patient. So all these interventional procedures, what I discussed, these are advanced procedures. We have multiple such interventional procedures available for the chronic pain patients, for the degenerative conditions of the spine, for the degenerative joint conditions like osteoarthritis or severe arthritis. In those cases, we have a lot of plethora of the conditions where we can manage these patients with the minimally invasive interventions. We do have limitations, we do have contraindications. It is not that any patient coming to us, we can jump on the interventions. Some limitations are there. There are some contraindications, complications, because these are the interventional procedures. We are not doing anything in non-invasive techniques. These are invasive techniques. So obviously they have some complications which may happen, but almost obviously these are very, very, very safe as compared to the open surgical techniques. Not an alternative surgery where the motor loss or something is there. In those cases, we have to go for the open surgical methods. So this is all from my side. Thank you so much. Thank you, Dr. Gupta, Dr. Sabu, for giving this opportunity. Thank you.
Thank you, Dr. Pankaj Surange, for advanced pain management, highlighting it very excellently. And a very good hope for diabetic neuropathic patient, spinal stimulation is there. Thank you very much. I invite next speaker, Dr. L. Srinivasa Murthy, for managing hypertension with diabetes topic. He is senior consultant physician and diabetologist at Lifecare Hospital Research Center at Bangalore. He is a former consultant at Fortis Hospital, Glen Eagles, Global, and Apollo Hospital. Over 2 decades of experience having undergraduate and postgraduate teaching. He has faced successful US FDA audit in the field of research and faced world's first ever Canadian audit successfully. He is principal investigator in more than 75 multinational clinical trials. He has received Inspiring Diabetologist of India 2022 award from Economic Times. He is a national lead investigator for India in multinational phase 3 study. He is GCP trained, fellow of ACPI, ICP, RSSDI, and Royal College of Physicians, has national and international publications. He is faculty at various national and international conferences and participated in more than 100 live TV shows. He is life member of RSSDI, API, CSI, AARO, Endocrine Society, and many more.
Thank you,
He
ma'am.
is
Thank
governing
you.
counseling member of many associations. Thank you.
Thank you, ma'am. Thank you for that kind introduction, and I sincerely thank Bansi sir for inviting me here, and I think that was automatic claps. And the topic is managing hypertension or diabetes, advancing beyond the arbitrary BP numbers. All of us know the problem, burden of hypertension and diabetes, and it's really a growing global menace. And look at the patients with diabetes, and by 2040, these numbers will be prevalent in 10% of the world's population, and 50% of these will be in our Southeast Asian countries. And that's what is most worrying. And this is the patient's diabetes and hypertension together, put together. Look at the numbers. It is 73% of them. And in India, the hypertension prevalence, 1 in 2 patients with diabetes have hypertension. So literally, alternate patients have hypertension and diabetes together, and that's our bread and butter, literally, to be frank. And hypertension is twice as frequent in patients with diabetes compared with those who do not have diabetes. And that's the relationship we should understand and try to tackle both together. And this is a trends in prevalence, an Indian view. You look at all the studies quoted from India. So the prevalence ultimately boils down to 25% in the urban areas and about 10 to 15% in the rural areas. Again, a worrying factor. The rural area is fast catching up, and look at the prevalence in various studies. And as Asians, we are at a greater risk of adverse effects related to hypertension. This is another worrying point, the uncontrolled hypertension, the burden, plus the risk of adverse effects related to hypertension. So as I said earlier, 74% of diabetes have hypertension associated, and this is what is the other comorbidities seen with that. And again, look at the results from this site study where the overall prevalence of 20.6% was observed, with the highest number reported in Maharashtra. This is something, again, to be worried about, and we know hypertension increases the risk of diabetes complications as well. So look at these relative risk complications on the right-hand side, diabetes versus no diabetes, and that's very, very important. And diabetes plus BP versus diabetes alone, look at the relative risk increase with the CHD, stroke, retinopathy, all the other complications. And of course, proportion of diabetic complications attributable to hypertension, just to tell you the attributable risk is with respect to stroke is 75% and CAD 35%. End-stage renal disease, one of the commonest problems we face, which literally doesn't have any treatment with us, and that is 50%. High diseases and leg amputation, again, are 35% each. So the excess cardiovascular risk in diabetes is attributable to coexistent hypertension. And participants with hypertension at the time of diabetes diagnosis had a higher rates of all-cause mortality and cardiovascular disease than did people with diabetes without hypertension. Again, another worrying factor. And look at the all-cause mortality. The plus 72% when these two combine together, and cardiovascular is plus 57%. And that's something all of us should be aware about. So just to ask a question, the august audience, among your hypertensive patients with diabetes, what is the percentage of target BP which most of us in our practice achieve to our patients is 130, 80. Do you achieve literally these numbers? I think it's about 20 to 40%, to be frank, in my practice also, for various reasons, of course. So this poor control rate is seen in patients with hypertension and diabetes. So only 1 out of 2 patients of hypertension with diabetes achieve the target. That is about 56%. 44% remain uncontrolled despite antihypertensive treatment. So patients are 7 times more likely to remain uncontrolled due to non-adherence of the medication. That's the point I want to highlight, the non-adherence, non-compatibility with the treatment. Remember, after 3 drugs, the adherence drops down to 70%. That means 30% of the times they don't swallow the medications, whatever you give. So that's something all of us should remember. The compliance adherence is what factor we should consider, apart from the which hypertensive you use. So majority of the diabetic patients have uncontrolled hypertension despite therapy. Again, I'm showing the Western data. We just saw the Indian data as well. So the poor control rate of hypertension among patients of diabetes are due to several clinical conditions. And diabetic patients renders a patient high risk for renal and CV complications. All of us are aware. Possibility of resistance to antihypertensive therapy in the treatment of diabetics would be probably change in the RAS activity, the central sympathetic hyperactivity, which as Indians we have little more sympathetic tone, the volume overload, lower BP goal, and the last one is a poor compliance. Again, a major factor in our busy practice. None of us stress, none of us ask them about the time of the antihypertensive therapy or the consistency of swallowing the pills. We do not bother about. I think that's something all of us should be catering to our patients about the poor compliance with respect to the anti-diabetic therapy. So what percentage of your hypertensive patients with diabetes are treated with a single pill combination? This is to overcome that poor compliance and the adherence part.
20, 20 to 40, 40 to 60. I mean, most of us, again, do not choose the ideal combination or the single pill combinations in our practice, so it will be as low as 20 to 40%. So we need to aggressively manage the hyperglycemia and hypertension, both with the same intensity. And remember, the chasing A1C will not translate into the cardiovascular benefits as you chase the BP. 10 millimeters of systolic BP can bring down 50% of cardiovascular risk. And that's the amount you get benefit translate to your patients if you control the BP tightly rather than chasing your HbA1c. That's something all of us should remember in our practice. So what does the international guidance recommend as an antihypertensive treatment? It's a RAS plus diuretic combination. Both ISH and ADA talks about that. And you look at the ADA statement, 2 drug or SPC, single pill combinations are recommended now by the bodies, though in India we've been using from ages all these complications, the combinations of drugs. So for hypertensive patients with diabetes, what is the preferred combination therapy? AS diuretic or CCB, AS ARB, CCB or ARB diuretic, all these permutation combinations without beta blockers. Of course, these are all the international recommendations, but in Indian context, we do use beta blockers in a certain niche patients. So what is the best evidence till date we have is about intensive BP control. This is age-old, the records I'm showing here, the ACCORD, DREAM, all these add the risk of stroke reduction in the group with the active treatment and a tighter control. This HEART trial showed CV events reduced in diabetic patients at a diastolic BP of less than 80, but not in non-diabetic patients. So that's something we should. And this is the UKPD's BP control study where about 1,148 patients were randomized into 2 arms, less tight and tight control. Those who are on not antihypertensives, those who are on antihypertensive therapy. You can see both the goals were fixed. And what were the results? The tight versus less tight pressure control. You can see the tightly controlled reduces CV events in newly diagnosed type 2 diabetes. That's the UKPD's finding, which is again very, very important data. And this is the CV benefits you get, whether the reduction of heart failure, the amputation or microvascular endpoints, all these extracted from the UKPD's hypertension harm. And this is the benefits we get out of tight control of hypertension. So again, showing the same data where the tight control 758 and less tight control 390 over patients, when look at the stroke, any diabetic endpoints, diabetic death and microvascular complications, all were significantly reduced in the tight control arm. This is again, I'm showing the various randomized control trials wherein in diabetic patients, the systolic BP reduction, including UKPDS and HEART trial, which I showed you earlier, have clearly shown the CVD risk reduction, which is significant. So let us talk about quickly about the advanced BP lowering, the forgotten twin combination which been there based on these trials which we have already neglected so far. And remember, ADVANCE had about 500 Indian patients also. It was a landmark trial with 11,000 plus patients. Primary endpoints, macrovascular outcomes and microvascular new or worsening nephropathy and diabetic eye disease I can see. That was the secondary endpoints. And significant reduction in CV and renal endpoints with perindoprolol indapamide was seen. You can see there combined micro and macrovascular events reduction. The primary endpoint, total coronary, total renal events, and very significant. You can see the p-value significance there. And both these were significantly the total renal events and the primary endpoint of MACE events were reduced 9% and 21% respectively. And this is the summary of renal benefits in the other trials called PREVENT, REGRESS, and RETARD, where the USUR was basically more than 150 and it normalized. Further comments about the end organ benefits of perindoprolol and indapamide is the proof of vascular legacy. These patients were followed up for 10 years and there was a CV mortality of 12% and all-cause mortality of 9% reduction even after following for 10 years. That was called as ADVANCE on segment. And in these hypertensive patients with diabetes, the SPC should be initiated early and continued long-term at the optimum dose of sustained vascular benefits. So this meta-analysis clearly shows that the effect of AS versus ARBs in the all-cause mortality, CV deaths, and CV events in patients with diabetes. You can very clearly see the AS versus placebo and the active treatment. The risk reduction with respect to the primary endpoints are significant. Some of them are significant with the statistically. And ARBs versus placebo definitely is something which we need to think about because there is no solid data so far with respect to the ARBs. So AS inhibitors reduced all-cause mortality, CV mortality, major CV events in patients with diabetes. This is the Cochrane review, which is again, we know the value of Cochrane review whenever it is published, the antihypertensive agents for preventing diabetic kidney disease. So you can see there, outcome in the AS group versus no treatment group, new onset kidney disease, all-cause mortality, doubling of serum creatinine and blood pressure reduction. You can see the number of studies they've reviewed, and they found that the ACE inhibitors prevent new onset diabetic kidney disease and death, and in normoalbuminuric people with diabetes compared with placebo, and benefits from ARBs, you can see on the right hand side, for people with diabetics should be interpreted with little caution. Now, strong and relevant outcomes of advanced versus ARB studies, you can clearly see again there, the SPC of perindopril indapamide had a reduction in renal outcome by 21%, reduction in mortality by 18 and 14% respectively, whereas on-target roadmap with olmesartan, telmisartan, irbesartan, you can see the reduction in mortality was not seen, though there is a reduction in renal outcomes in all these trials. What about the evidence of BP reduction with perindopril and indapamide combination? This is the latest publication in 2021, where the significant BP reduction with perindopril and indapamide with the pooled analysis in diabetic patients was clearly seen. You can see the systolic and diastolic BP reduction. And patients uncontrolled on perindopril indapamide, additional advantage of switching to triple drug. Again, we're talking about compliance here and the combination of synergistic combinations of triple drug with perindopril, indapamide and amlodipine, which clearly showing the strong BP reduction along with good mortality benefit. This is called as a proof study, and there is one more study called pianist study, wherein the reduction is 37 and 17 systolic and diastolic respectively, very clearly, and these are comparable to your advanced study as well. This is our own Indian study, which was published in JAPI. We were part of this clinical trial also. Mean BP reduced by about 30 by 15 millimeters of mercury in a span of 2 months. End of 60 days, the patients reached this target. We had about 218 patients, and it was a very significant study with 91% compliance rate and 99% patient satisfaction. This is another latest study, which is called as a Brisigella study from Italy, where they studied the percentage, they studied the patient for about 12 years with this combination, and look at the better preservation of metabolic profile and lowest MACE incidence were seen with this combination versus ARBs and the other. It was a 10-year-old study. So to summarize, excess cardiovascular risk in diabetes is attributable to coexistent hypertension. Hypertension is difficult to control in patients of diabetes due to clinical conditions such as volume overload, change in the RAS activity, and central sympathetic activity. The advanced trial clearly showed that the perindopril indapamide provides significant CV and renal benefits that are sustained over a long time, and in view of differential benefits on mortality and morbidity, the ACE inhibitors appear preferable, which most of the bodies also say ACE inhibitors / ARBs, and new pooled analysis suggests that the SPC of perindopril indapamide is very effective in reduction of BP as early as 2 months in our Indian context, and this triple drug combination with perindopril indapamide amlodipine provides strong BP reduction, and treatment with this triple drug shows total mortality reduction by about 28%. Thank you very much for patient hearing. Any questions, we'll be very happy to take up.
Thank you very much for excellent presentation. Thank you, sir. Any questions?
Thank you.
Okay. Thank you, sir. So now I would request next speaker, Dr. Bhavna Shosle. Ma'am is going to give a talk today on an advanced study which is re-establishing the relevance of glycemic control in management of type 2 diabetes management. Madam, she is MBBS, MD Internal Medicine, MRCPS, FRCP, and she is already a fellow of RSSDI. She is right now Director of Diacon Hospital, Bangalore, and a Vice President of a Primary Academy of Medical Science. Ma'am has been a principal investigator and a co-investigator in several clinical trials in field of diabetes, hypertension, severe risk, artificial intelligence, and diabetic retinopathy. Over to you, ma'am.
Thank you so much, and thank you to Dr. Banshi and the organizers of DiaCareCon for inviting us to the event. So it's wonderful to spend the Sunday with all of you here today. So we've got this whole session on advances in pain management, advances in blood pressure control. I don't know what that was. And now advances, we're going to look at the advanced study and look at what we can take away from that with respect to blood glucose management. Now, the first thing when we look at any study is a few questions that we ask ourselves. who are the people included in the study? Do we see the same kind of patients in my practice? Because that is what you need to see. And then based on the results of the study, you would know if you could apply the same kind of results, if you can expect to see the same kind of clinical effectiveness when you use a certain molecule in your practice. So that is what we're trying to look at the end of this talk. Now, we know from several studies that early aggressive glucose control is important. And now what the UKPDS told us was that reduction in blood glucose levels and A1C translates to microvascular outcomes. Translation to macrovascular benefits was not really seen initially, but it was seen in the follow-up. So it took a much really longer time. But it left us with one lingering question, which was how intensively lower can we go? And what happens if we get to a A1C less than 7, say 6.5? And that was the objective of the advanced study. So they were trying to ask the question, what happens if we do intensive glycemic control in the group of patients to get them to A1C below 6.5, and then in another group, just do conventional management. And these were all patients with type 2 diabetes at different levels of blood glucose levels, but they were not patients taking insulin. So they were all patients on oral anti-diabetic medication. Now, the study included close to 11,000 individuals, and 470 of them were from India. The average age was 55 years, and they were patients with type 2 diabetes on OADs. So the mean A1C at the enrollment of the study was 7.5%. Now, many of these individuals already had a history of a vascular event, or they had risk factors that could predispose them to a vascular disease in the future. Now, what happened to the glycemic control? In the intensive arm, compared to the standard of care arm, the intensive arm reached their target of 6.5. So that was what they wanted, and they reached that arm. And the intensive arm, the A1C dropped in people irrespective of the baseline BMI, irrespective of their age, and irrespective of the duration of diabetes. So at whatever duration of diabetes, age, or BMI the patient fell, whichever category the patient fell into, everyone in the intensive arm could achieve the A1C of 6.5. So what was used again to get to this intensive control? It was extended release glycoside. So that was the molecule used to get patients to the A1C of 6.5 in this particular study. Now, but this was not, of course, the primary endpoint. What was the study trying to see? When I use modified or extended release glycoside in patients to get them to A1C of 6.5, what happens to the overall vascular event? So the combined major, macro, and microvascular events. So at the end of the study, which was a 5-year follow-up, the study reached its goal. So there was a 10% reduction in combined events in the intensively controlled arm compared to the standard of care arm. And a lot of this benefit was actually seen due to improvement in renal outcomes. So yes, there was an improvement in overall microvascular outcomes, CV death, total mortality, and also in macrovascular outcomes. But the biggest change and the benefit driving this overall, the biggest change that drove this benefit was the improvement in renal outcomes. And this was all just with 5 years of intensive control. So there was a reduction in new onset microalbuminuria, a reduction in new or worsening of nephropathy, and reduction of new onset macroalbuminuria. So what we learned from this at this point of time was we can get to intensive control, get patients to 6.5 A1C using this particular molecule, and there is an overall benefit on micro and macrovascular outcomes, and there's a much greater benefit on kidney disease outcomes. What we also take away is that getting to intensive control did not increase the risk of cardiovascular events, because that is again something we're traditionally worried about, that getting patients to too tight control, too strict control may increase the risk of cardiac disease, and that did not happen. So there was overall benefit in all micro macro outcomes, a greater benefit in kidney outcomes, no increase in CV events. Now, there was a reduction in end-stage renal disease by about 65%, a reduction in relative risk in the intensive control arm, and reduction in all the different outcomes related to the kidney. There was also improvement in progression parameters. So it was not just prevention of new onset kidney disease. People already had macro or microalbuminuria, they could regress, and people who did not, the progression was much, much lesser. So there was a reduction in new onset micro and macroalbuminuria, and there was regression of nephropathy by more than one stage in about 15% of the patients, and regression to normoalbuminuria in 20% of the patients in the intensive arm with gliclazide. So what was the number needed to treat? In the overall study population of all the people, healthy and those with vascular disease, the number needed to treat was 400 plus. But in those who already had pre-existing kidney disease, so micro or macroalbuminuria, or just macroalbuminuria, treating them to target 6.5 made a bigger difference. So in those who already had macroalbuminuria, the number needed to treat to prevent one end-stage renal disease was just 41. So treating even a very small number of patients over 5 years, getting them to control and making sure that they stay at control, we can prevent renal events in our patients as well. So that's how we would translate that if we have to use this evidence in our practice. But that's not the end, right? Because we see patients for much longer. It doesn't end at 5 years. So what happened later on? So the advanced on study continued to follow up all these individuals. And then some patients were lost to follow-up. So from 11,000, you see the numbers came to about 9,000 in the end, 4,000 approximately in each group. And then these individuals were followed up for another total of almost 10 years. Now in this follow-up time, even though initially they were randomized to intensive and standard of care arm, at this point of time, the HbA1c curves were kind of matching and there was no difference in the glucose control. But what happened to the renal outcomes? What we see is that the initial benefit that was seen in reduction of end-stage renal disease persisted even in at the end of the follow-up of 10 years, and there was a relative risk reduction of almost 50% in those who had initially got intensive control with gliclazide. This benefit was greater in people who had no CKD and people who had early CKD like stage 1, stage 2. Not so much of a difference was seen in those who had advanced end-stage renal disease. So maybe there was some threshold that patients were crossing, after which it was not making too much of a difference. Now, irrespective of what level of kidney disease the patient had, there was an improvement in the A1C level. So whether their GFR was more than 90, 60 to 90 or under 90, all those in the intensive control arm responded better. Irrespective of the GFR subgroup or the level of kidney disease that the patient was in, there was no difference in the overall benefit. So we know from the results of the study that there was a benefit in micro and macrovascular outcomes, and this did not change based on baseline variables like the GFR, and there was no change in CV death, all-cause death, or major coronary events based on the GFR levels. There was also no change in the worsening of new onset nephropathy based on the baseline eGFR levels, or based on the UACR levels or the KDIGO risk score. So we'll not look at the numbers and all these figures too much. What we take away from this is, irrespective of which level of kidney disease the patient has or what level of UACR or GFR the patient has, if we get them to intensive control, there can be a benefit in long-term progression of kidney disease. So we could maybe stop it somewhere in between. We could maybe even regress it in a certain number of patients. Now, does this change based on the baseline ASCVD risk? So we know that the overall benefit does not change based on the level of kidney function. So we just looked at that. So does the is there a change based on the baseline ASCVD risk? And this is what a subsequent subgroup analysis actually told us, that irrespective of how you classify the patients as ASCVD risk below 20, 20 to 40, or more than 40, there was no overall change in the benefit seen with intensive control. So don't worry about the numbers, but look here, you see major vascular events, macrovascular events, and microvascular events. So all the overall benefits that you see with intensive control, getting patients down to A1C of 6.5, we expect to see the same benefit irrespective of whether the patient has cardiovascular disease or not. So what I'm trying to say is, in another way, there's no increased risk of cardiac events in patients who get to intensive control with gliclazide, and that's from the data of the ADVANCE study. Now, this is again another slide which is depicting exactly the same that you saw in numbers in the previous slide. So irrespective of where the patient's, so it's slightly different. So irrespective of what the patient's A1C is, we see an improvement in the macro and microvascular events. So there's no change based on the baseline A1C. There's no change based on the baseline ASCVD risk score. So we expect to see the same kind of benefit irrespective of patients' BMI, irrespective of patients' age, irrespective of patients' baseline A1C levels, irrespective of patients' baseline kidney function and cardiac risk. So what do we learn from all this data that we've got over the years from the ADVANCE trial? That intensive control, getting patients to goal is important. We know that getting them to goal early is probably necessary, and it can prevent long-term damage. Now, this study told us that the greatest benefit was actually in terms of improving renal outcomes. So that is something to keep in mind. So it prevented progression of nephropathy, helped in regression of nephropathy, and this benefit can persist even if the patient subsequently has poor control sometime later in their life. But of course, we don't want our patients to have that. The other thing that we take away from all the different subgroup analysis is that whatever their baseline A1C may be, whatever their baseline EGFR may be, or cardiac risk may be, we could hopefully expect to see the same kind of benefits in terms of renal and CV outcomes in our patients when we treat them to target using this particular molecule. Now, why we looked at the ADVANCE study? Because it represents a lot of patients whom we see in clinical practice, patients with diabetes, different duration, on OADs. This study didn't include patients on insulin, but I would say even patients on insulin, getting them to goal is obviously necessary, so it's not that we would treat them differently. Modified release gliclazide, remember, is a modern sulfonylurea, so risk of hypoglycemia is lesser. CV safety is not an issue compared to glibenclamide. So wherever possible, do use a modern sulfonylurea for management when you need to use SUs for treatment. Again, SUs do not cause beta cell exhaustion. We use SUs in practice for years, even when patients are on insulin. Otherwise, the dose of insulin goes up by 3x or 5x, and patient who could just take a basal insulin ends up on 3 injections a day when we take away the SU. So this is not a part of the study, but please do consider using SUs when you do initiate patients on insulin as well. So I think those are the takeaways from the ADVANCE study, but basically get them to goal, get them to strict targets, and avoid hypo as much as possible. And we can expect to see the same kind of long-term benefits and prevent complications in our patients also. So thank you very much.
Thank you, Dr. Bhavna, for highlighting ADVANCE study. Thank you very much. Any questions?
Yes,
practical and clinical questions. Still we know the data from ADVANCE on, and so promising data, but the uses somehow suddenly changed across the country from AC inhibitor to ARB. And in ARB also what we are seeing is, telmisartan molecule, even it's not a strong antihypertensive, and the data was on target, which was showing that it is as good as what the HOPE data of Ramipril. It was near compared, and in India we don't have any comparison between perindopril and this. So why so? Is it the marketing? Is it because telmisartan has been sold by 40 companies which are responsible for its increasing sale? Why so?
I think you answered the question, sir. Made it very easy for me, so you gave me the answer there. I think it's mostly about marketing, what is available and told to doctors. So what is available more easily for patients to buy, that is what gets prescribed more also. So I do not really know why ACE inhibitors never picked up that much, but probably this could be the only logical reason, because there's a lot of data to support the use of ramipril, perindopril, enalapril, and today the usage is very minimal compared to ARBs. And again, in ARBs, there are so many, and there's data with valsartan and so on. But we all, many of the companies come and then everything left on our table says telmisartan. So maybe it's just a brand recall and reminder. I don't see any other scientific explanation for this. And maybe also availability of combinations in different strengths, doses for patients to take, that might also make a difference. I think they are happy with the answer. They nodded. So
Thank you. So I think we should conclude the session here, and I will. No. And I'll request everyone here to join the validatory function in Banting Hall. So I think supposed to be in the next few minutes.
Yes. Thank you.
Yes. Thank you.